for independent living, benefits counseling. So a number of other services that are really helpful to support that unit. So sorry, I'm just getting a Zoom message that I'm trying to click out of. So the next slide really walks you through an evolution of services. So it gets a little tricky when we talk about what services we used to have, what services have been eliminated, what we have now. So we thought maybe breaking out a couple of the functions and then walking it back a little bit might be helpful. So what used to be the Commission on the Deaf and Hearing Impaired, or CDHI, was folded into our department when we were created, which happened on July 1st, 2011. So CDHI became part of our department at that point. So prior to the consolidation, so prior to July 1st, 2011, that column of prior to consolidation shows that there was an executive director, an administrative assistant, 2 counselors, 2 interpreter coordinators, 3 clerical staff, and 37 part-time interpreters. After the consolidation, so as of July 1st, 2011, the executive director position and administrative assistant those positions were eliminated, and our commissioner's office assumed those responsibilities. The 2 counseling positions carried over, and then we had the interpreting unit carry over. In July of 2016, when there were a lot of other budget changes going on, we had a very challenging budget year. The interpreting unit was eliminated and the interpreting services for the state of Connecticut were privatized. There was already a hybrid model where the state agency was providing interpreting services and there was a private entity also providing interpreting services, but kind of 2 primary interpreting service centers in the state, us and LifeBridge. But at that point, back in July of 2016, the interpreting services were privatized because that model had already started. And so the interpreting unit and the positions that were associated with that were eliminated at that point in time. Jen, do you want to go to the next? So this slide talks a little bit about what some of the services were prior to the consolidation and then what they look like now. Clearly, you just saw the staffing. So the size and scope or quantity and scope of what we can provide is potentially different given that we have fewer staff, but we are still able to provide through our human services advocate and our social services block grant counselor accessibility services, advocacy, service coordination, counseling, and information and referral. We're not doing any educational outreach or not on any grand scale, not doing the policy and legislative advocacy work specific to that population, although I am a member of the Deaf and Hard of Hearing Advisory Board. And then public awareness hasn't been done to this point, but we were able to use ARPA dollars working with the American School for the Deaf, who just launched a pretty comprehensive public awareness campaign about issues and access for individuals who are deaf, hard of hearing, or deafblind. This slide just walks through some of the examples of services that, digs a little bit deeper. We don't have to get into all the details now, but, for example, it talks about us working on how assisting people with housing and financial assistance. And so a couple of the bullets under that are that we connected individuals with housing programs, financial resources, addressing concerns about rent increases and providing support. So we do that in collaboration with other organizations, with the state agency that maybe has primary responsibility, but really helping somebody who's deaf try to navigate the system. And we collaborated with financial professionals and advocates to assist clients in managing finances. Also on the interpreter coordination piece, which I know has been a concern for this group, we worked, we managed the Connecticut Interpreter Registry, ensuring that any interpreters we have in the state are properly registered and available for services. And our human service advocate and our counselor both address concerns and issues related to interpreter services, helping them learn how to advocate and advocating with our organizations and the broader community for accessible communication in different settings. The next two slides are just a sample of the services that our counselor provides and then our human service advocate. So our counselor is funded through social services block grant funding. So there's some very specific guardrails for her. She needs to be working with individuals who are at or below the federal poverty level, and it falls within a protective services category. So these services are things that that she's able to provide. This is a quarter worth of data. We thought it might be helpful for you to see by age and service type. And these are duplicated services. So all of that's reflected on the slide, just to give you a little bit more of a sense. And then Jen, the next slide. I know one of the things that this committee's been interested in is sort of how the agencies work together. And so this shows that our human service advocate does work with many other state agencies, trying to help the agencies develop responsive, communication strategies, and also helping individuals navigate through our systems. So that's the information on deaf services. I'm going to pause for a second before I hop into the next topic, which is elderly nutrition, and just see if you have any questions. And if that's how you want us to proceed.
I think that's great. Can I just say thank you for doing this, because it's really, I wish some of the other agencies could do that clearly, because we know that all the agencies right now are suffering from lack of staffing. But what I would like to know is, do you have any lapsing in PS or OE because of the fact that you don't have your full complement of staff?
No, the funding that was associated with any of those positions would have been gone back in 2016. And 2011 first and 2016 after that. So the fund, for example, the funding for the executive director and the executive secretary never became part of our agency because those were eliminated as part of the consolidation. They were a standalone agency, then they were becoming part of a larger structure. And so those positions were eliminated before the budget even came to us.
Thank you. So as far as you have no lapses whatsoever in your budget then?
Because of these positions, we don't have any lapses.
But do you have any lapses for anything else in programming?
We have had some additional PS, but it's because of vacancies, and we are working to fill all those vacancies and have, we've had really a very productive recruitment process with all of our vacancies. We got hit hard just as everyone else did. So we did have a chunk of vacancy savings, but all that funding will be accounted for in the next budget.
So, okay, so there are no, try it one more time, no lapses in your budget anywhere.
I don't, that's not what I'm saying. We do have some lapses. Jasmine, are you able to pull those up?
Yes, yep.
Okay.
So according to our last CFSR submission, we are not any lapses in PS due to the holdbacks. But we, as in the deficiency bill, we were showing 200,000 for children's services.
Okay, and can you answer why do you have a lapse in children's services?
And of course, I'll circle back and just make sure I'm verifying the information, but that was due just to the vacancy, but we are actually filling those positions.
Okay.
We're currently recruiting for two teachers for the visually impaired.
Okay, so you have two teacher positions that are open. That would be equivalent to the 200, but for the visually impaired. Okay. All right. Okay. Okay, Jillian, you have a
Great.
question?
Yes, thank you.
Mhm.
If you could go back to the slide on the difference before and after consolidation with interpreters. Let's see. Yes, thank you. So could you just talk us through briefly? I know that we don't have all the time in the world, but what it looked like those 37 interpreters, how were they used, and then what does it look like today in your department?
Right. So those individuals were available. They were state employees and state employee interpreters, not in full-time positions, although there were a few that were in full-time positions, but the majority were part-time positions that sort of worked on an as-needed basis. So somebody called, asked for an interpreter, and they were matched. We had 2 interpreter coordinators and 2 support staff that did matching to make sure that the individual who is deaf might have some specific needs for an interpreter. They might need, a tactile interpreter. They might need, they have specific needs, and maybe a specific list of individual interpreters that they work really well with. And so they might have some preferences, or it might be availability of the interpreter, area of the state. Maybe somebody's already working in the area. So the 2 interpreter coordinators and their staff really did a lot of juggling to make sure that people got the access that they needed, and we were able to utilize these state employee interpreters. Now, many of those interpreters have gone to work for private entities, and so there are multiple private entities. And so when there's a doctor's appointment, it should be the doctor's office calling or the hospital calling and setting up for an interpreter, but there are multiple agencies that they can go through. There is a list of agencies available on 211. And then for state agencies, because state agencies are following potentially stricter contracting rules, we do have a master agreement where a state agency, if I need an interpreter for a meeting or Demas needs an interpreter, they can go to the master contract and get interpreters and work with those agencies that are on that contract. So it's all privatized at this point. We have some of our own staff, but our interpreters are hired to work with our deaf professionals and be like a one-on-one as an agency, but we do not have a statewide interpreter unit.
Okay, thank you.
Are there any other questions from any of the other members from the committee? Okay. Going on.
So next, and I know we have a lot to cover in a short amount of time, so I'll continue to try to go quickly. There's just one slide for elderly nutrition. So there were questions about the allocation, the ARPA allocations and the state funding for ARPA. So, for elderly nutrition. So we were able to use 2.25 million in ARPA funding, and we allocated 1.5 million of that directly to our area agencies on aging based on the formula we already have in statute for distribution of funds to those groups. And that was to help bridge costs due to the expiration of COVID funds. And then we were able to give 750,000 directly to the 11 local nutrition providers based on federal fiscal year 22 service levels, and they could use that for capital expenditures, emergency meals, or increased COVID-related costs. I see, let's see, do you want me to?
Senator Lester, is this about the nutrition, or do you want to?
I have a question about nutrition, but I can wait if you're still talking about nutrition.
Go right ahead, sir. Go ahead.
Okay, thank you. So the top recommendation of the Elderly Nutrition Task Force was to try to restructure the program to carry forward a few months at the start of the federal fiscal year. Are there currently ARPA funds that we could allocate for that purpose that within ADS?
Within ADS,
It'd be a one-time, it would be a one-time, yeah, we would need like one-time funding to restructure the program at the start of federal fiscal year. And I'm just trying to figure out where, we got to figure out where that's coming from if that's the case.
Yeah, we do all of our ARPA dollars that were for elderly nutrition have been allocated already. And as I said, some of those went directly to our nutrition providers. So we don't have additional ARPA dollars that we could do that restructuring with at this point.
Okay, great. But I would hope, this is a offline conversation, but that the department would work with this committee and Human Services on that, assuming we're able to find the source.
Yeah, we're happy to work with you. We agree how critical this service is for folks, but we also recognize it's not an entitlement program. So the funding we can certainly look at. We do have we only get X amount of funding from the federal government and from the state, and so those budgets are set at the beginning of the year. So we do know what those are, and we would be happy to work with this committee on trying to, move forward in the most effective way.
Thank you, Commissioner. Please continue, sir.
Thank you. Representative Polinsky.
Madam Chair. Commissioner Porter, thank you so much for a wonderfully organized presentation. Question I have about elderly, kind of a lot of nutrition providers in three that were complaining of late payments or not being able to get their hands on payments, and then they're talking about having to change schedules and all that. Is there anything that's still outstanding with any of these providers, or did we actually fix that down?
You were, at least on my end, you were cutting in and out on that, but I think I understood the question to be that there were concerns about late payments, and are there any payments outstanding at this point? Is that accurate?
That is accurate. Thank you very much.
Okay, great. Yes, we heard those concerns as well. We did, as part of the retirement, we lost the majority of our fiscal unit. And so we did have some delays. We are caught up, 100% caught up in those payments. So there are no outstanding payments to either our area agencies on aging, who are really the conduit to our elderly nutrition providers, typically, with the exception of the ARPA dollars that we got to them directly, but typically it goes through our area agencies on aging, and we are up to date with those payments.
Very, very much. I appreciate all your.
Great, thank you. I see Rep. Dillon, you have your hand raised. Is this specific to the elderly nutrition?
Yes, ma'am. And I apologize, I've been in and out of meetings, but did I understand you to say that there was a formula used to distribute the dollars in the AAAs and in the local providers? Is that true?
So for the AAAs, there's a statutory formula for how we distribute the money to the 5 area agencies on aging based on population. That's required in the Older Americans Act, because that's where we get the majority of our funding from. For the local providers, it was actually based on their service levels for fiscal year 22. So that wasn't a formula so much as the year, basing it on a base year of service.
Okay, thank you. Yeah, the testimony was very moving on this topic. Thank you very much.
Thank you.
Thank you. All right, feel free to continue on.
Okay, senior center grants. There were some questions about that. I won't go into detail given time, but what we did put in to the presentation is kind of screenshots of the various sections of what the applications looked like for senior centers. So to give you a sense of what's actually in what we're requiring of senior centers at this point. We did listen to your feedback. We are trying to streamline as much as possible. And I think I mentioned last week that our senior center liaison is also offering office hours every Friday to walk any municipality or senior center through this process. We're also going to post on our website based on your questions and feedback last week. We're going to post an example. And also here's what some of your peers have applied for, maybe just to make that easier, because we heard in the meeting last week that sometimes it's a volunteer that's trying to pull this together and maybe they just, it feels overwhelming. So we're going to try to simplify that as much as possible. And then I think we can, we just have a few minutes left. So the final area that the committee was asking about was our long-term care ombudsman program. So for one of the specific questions was about the staffing and the national standard. So our program currently has a state ombudsman, an administrative assistant, 2 intake coordinators who take the calls from all over the state, 8 regional ombudsmen. So that's to work with our skilled nursing facilities, our assisted living, and our residential care homes. We also have started building our community ombudsman program. So we have a manager there and a regional ombudsman. We can't use federal funds for them for some of their car, their computer, their phone, their data system, because that's a state funded initiative. But for the regional ombudsman, that's what we'll focus on here. There's an estimated 30,000 beds in those facilities in Connecticut, and the national recommended staffing standard that was set back in 1995 it suggests 1 FTE per 2,000 beds. So that equates to 15 regional ombudsmen and a supervisor to support their work, which would be an increase of 7 ombudsmen and a supervisor. So that takes the community ombudsman program out of it, but gives you a sense of based on the staffing pattern and what we have currently. And then we also included a few slides to give you a sense of what's been changing. So the next slide is total complaints for all settings that shows the escalation over time. The slide after that shows the types of complaints where the primary is in the area of care. The next highest number of complaints is in autonomy, choice, and rights, and the third is admission, transfer, discharge, and eviction. The next slide shows some trends over time, particularly with nursing home staffing and administrative oversight complaints. And then the final slide that you'll have available to you shows the workload for each of the regional ombudsmen over the past 15 years, and gives you a sense of how many ombudsmen we've had. You can see that that's remained fairly static, although we're down 1 over time when position was eliminated, and then the total complaints per ombudsman. And I think that's the last slide.
Great, thank you. I think this is obvious, but just want to confirm. So complaints, then the cases would be, like the complaint could be resolved quickly. The case would be one that needs more ongoing assistance.
Let me just see where that terminology came from. I think that's a good question. I can get you information that differentiates this. I think these are all complaints that we presented here.
Okay. Anyone else? Thank you so much. Anyone else questions? Comments?
Amy, I just want to thank you. I don't know about you and my team here, but this was really a thorough report. And in 30 minutes, I got probably a lot more than I do in 3 hours with some people. So, and I feel your pain. I feel your pain about your staffing. I really do. But I'll be honest, the detail that you provided us, I would love to get from some other agencies. So I just want to thank you for how hard you're working and how you're trying to make sure that we understand what's going on. And I think that's really critical. Representative Belinsky, thank you.
Thank you very much, Commissioner. Commissioner Porter, you know that particularly the caravan and I are big supporters of the ombudsman's program. And the slide showing that we seen a trickling in complaints over over the last 8 months. That you what
Representative Belinsky, we're having a hard time understanding you.
I'm very sorry. Is it better if I lean forward and scream?
That's a little bit better, a little bit better.
Right. Just to shout out, Commissioner, the busing program is something that means an awful lot to Rep. Garabay and I, particularly in the aging committee. And what you accomplished with so few people, with a tripling of complaints over the past 7 or 8 years, is just absolutely amazing. So, thank you so much.
Thank you, sir. Thank you. Senator Lesser.
Sorry, at the risk of prolonging this love fest, I just wanted to thank you, Commissioner, for your staff's support of the Elderly Nutrition Task Force. We'll be working with you on the recommendations and also on the wheelchair task force. That help has been really helpful, and obviously an issue that will be 2 issues that we'll be spending a lot of time on this year.
And thank you. And yes, it's nothing wrong with us giving a love fest to an agency when they do such a great job of giving us what we are looking for. So thank you all. So, and one question, can we, will you send the slides to Madam Administrator so that we can all get these details of data that you provided us?
We will certainly do that. And I want to thank you for the praise for my team there. We have a great team, both at the direct service level and in our administrative offices here that work together on this presentation, but more importantly, the folks who work to make sure these services get delivered to the folks in Connecticut. So thank you all for your time, and we will certainly send these out.
As for the public hearings that we have, I want to give you a happy hands because you did a fabulous job. Thank you. Oh my gosh, you're sick. Oh.
I'm not sick. Something got in of course, when you're doing a presentation, your throat gets dry. And so now I'm coughing and crying and all of that, but I'm not sick. So okay. Thank you so much. I appreciate it.
Those are tears of joy for being good. Thank you. Have a good afternoon. Next, too. We have Department of Children and Families. Commissioner.
Good afternoon. Wow. Good afternoon.
You got a lot of people in that office. I hope you all wear a mask.
Well, I just have one request. I need some of those happy hands over here too.
Oh, okay.
So can we have
happy hands? Absolutely. Well, the commissioner set a good standard with the Department of Aging. So we expect DCF to do the same thing. It's going to be a continuous saga. Okay.
You got it.
Go right ahead, ma'am.
So good afternoon, Senator Lesser, Representative Gilchrist, Senator Summers, and Representative Belinsky. I am Jody Hill-Lilly, Commissioner Designate for the Department of Children and Families. We have I forgot to say the esteemed members of appropriations, including Tony Walker there. We've submitted our responses to the committee, to the committee's question, and we're happy to proceed basically however you want us to. We have our CFO who is going to be driving the PowerPoint presentation for us, and we have in the room subject matter experts ready and willing and able to answer the questions, any questions that you may have. So we turn it over to you as to how you would like to proceed. Go.
Why don't we just go through the question as quickly as possible, but with good detail so that people can ask questions if they have. Okay.
Okay, great. So Melanie, you want to sort of drive us there?
Yes, ma'am. So can you all see my screen?
Yes, ma'am.
Okay. So our first question was related to background checks for potential contracted star home providers. Commissioner, I will defer to you for context.
So yeah, I spent some time believe it or not, I went to a star home. I went to 4-star home, no, 3-star homes to visit. I asked questions about these, sort of the onboarding process. I reviewed documents. So I think I have a really good sort of understanding as to how they onboard their staff. And it looks, quite frankly, very similar to ours. So they do the fingerprinting for criminal background checks. They do the Child Protective Service background check. They do the motor vehicle background checks. I even went over their interviewing questions to see if they lent themselves to, sort of picking the best people for the job. And they have, I would say, everything that we have in place in terms of screening for anything that would prove to be unprofessional or not a good fit for our agency.
Commissioner, can I ask a quick question? You do this
Sure.
for all your contracting, correct? All contractors have to go through this. So it's not just Star Homes, it's everybody that has a contract with DCF.
That's correct. That is
Okay.
directly, the answer on the screen is direct contract language in all of our contracts.
Okay, so that's great. That's great. Thank you.
And
Okay.
we just want to, I just want to say explicitly that there really is no way to predict when someone is going to commit a crime of like the ones that we saw. And so, and we cannot, deny someone employment based on mental health history. It's illegal. So all we can do is try to screen for criminal history and CPS history and do our best to figure out what the applicant's strengths and weaknesses are during the interview process.
Okay. Question 2.
Question 2 is related to salaries for staffing in our star homes. What you'll see here is the delineation of direct and indirect positions in all of our contracted star programs, what shifts are covered by what positions. This does not equate to FTEs. There are more than, for example, youth workers. There's more than one youth worker on shift at any given time. It also includes their current average salaries based on this year's provider budgets that we have been given. And then question 2A spoke to whether or not salaries were commensurate with attracting high quality personnel. So what we did was look at the national average median salary for these types of positions in a nonprofit residential program, as well as the Connecticut average salary. So you have some basis to see what we're currently paying or what our providers are currently paying, because that's an important point. Our providers are independent entities and they set their wage and pay scales independent of us. But you can see where there are discrepancies for each position.
So Melanie, what you're saying is that you have a standard, but the standard does not necessarily translate to the contracts with the nonprofits. The nonprofits establish their own minimum wage or pay rate that's different, that could be different from DCF. So it's up to the provider. When they do their contract with you, are they required to provide us with what their pay scale is? So you do become familiar with what their pay scale is, correct?
Absolutely, yes. And this first column here, as well as the column above, is actually taken from what they provide us. Yes.
Okay. And have you, I guess my question to the team is, have you ever gotten to a point where you look at what they are paying and said that that is far too low for you in what you're paying, let's say a case worker or a child care worker, if it's less than $15 an hour or something? Have you ever made the changes or forced them to increase the amount for the employee?
The answer is yes and yes. So we do not approve any budget that pays less than minimum wage for any employee. We handled that a few years ago, and we ensured that everyone is making at least minimum wage. I could also, Commissioner, if you'd like, I can speak a little bit about what we're doing when we reprocure around salary parity.
Absolutely.
Post-pandemic, one of the things that we have been seeing is salaries, especially for direct care in-person work, are just shooting up far beyond what our normal funding would allow us to accommodate. But what that's translating to is an awful lot of staffing vacancies at the provider level. So when we go out to re-procure any service, what we're doing is taking a step back and looking at utilization like we always do, looking at need like we always do, but we're also looking at salaries, and we're looking at the staffing model that DCF requires. So we say you have to have this many staff of this type. But then we're also doing what I essentially did on this page, which is looking at national average median salaries and Connecticut average salaries to make sure that when we go out to bid, we might end up going out for less services, but we're making sure that we're going out appropriately funding the providers to attract within Connecticut average salaries and the national salaries. So we're really trying to take a look at that. It's a little bit slow going because it's predicated on how often we rebid. But that was a commitment that we had made to our providers that we're making sure that we adhere to.
I noticed you have a notation for nurse and for maintenance on here that says it denotes on-call positions. What does that mean?
So the nurse is on site set hours during the week for med administration and things like that. And certainly I'll defer to Dr. Gregory. But we make sure that it's not necessarily that the nurse is only staffing first shift. The nurse is on call for when the nurse is needed.
Okay, so it doesn't matter what shift they are, they're all going to be at that same price point, correct?
Correct.
Even if they're doing it in the evenings.
That's correct.
Questions, team? Anybody have questions? I see there's another part, a part B. What additional staff decreases incidents of assault by staff and residents?
Commissioner, you want to add some context around the STAR plan?
I'm thinking that should be Frank. Say your name.
Hi, Frank Gregory. I oversee community behavioral health services, and we do believe that additional staff and additional training for existing staff would help enhance services. We've also been told in a setting like a STAR home, the level of residential staff, as long as that's sufficient, that then enables other staff like clinical staff to be able to focus on more in-depth individual work with the youth. So we do believe that attending to the staffing ratios and what staff are being asked to do during the course of their shift does have obviously an impact on care. And we are working with the STAR providers on looking to address that calculation, if you will, and the appropriate numbers of youth and staff for a program and for quality care.
Okay.
You know, interestingly enough, I went to a STAR home, like I said, the other night, and I asked, the provider, I said, if you could have anything in the world that you needed in terms of staffing, what would it be? And the response was, it's not necessarily additional staff. I can't fill the vacancies I have, which points back to a staffing crisis. So that was out of the provider's own mouth. In addition to what Frank has said, is in terms of what we're trying to do, it doesn't negate the fact that we have a significant workforce crisis on our hands.
I agree, and I'm hoping that OPM and the governor's office are watching, because I think we're hearing that with every agency that we are having and suffering through a severe staffing crisis. On the with the STAR homes, you have a sort of a definition of a STAR home in your organization. Is that correct? Like,
Yes.
What they provide, the services that they provide, et cetera. You have that, correct?
Yes.
Yeah. Okay. So my question is, we did hear this in testimony as we've been going through, that sometimes because there is no other placement, sometimes you have to place people into these facilities because there is no other placement to put them in. Does that change the definition that is in statute for who gets the services in what facilities?
A couple of things. That's not statutorily defined in terms of, who needs what, setting. I think that, any child, actually who's placed in a star home is placed by the regional office in consultation with the licensed clinical staff in the area office regional resource group. So they are clinically assessed by DCF staff and as available, relevant, the providers that they may be working with in the community. So placement in the star home is as a result of that licensed clinician in the area office determining that this would be an appropriate setting. As you mentioned, acknowledging that it may not be, and it's not the optimal setting, right? We would optimally like to be able to support a child in a home setting, et cetera, but that it is an appropriate setting. We also attend to, and there's some language in the contract, if a child requires some explicitly higher level of care, like hospitalization or something, that's not a child we would put in the star home. That's part of that assessment that goes on. So it's a fairly intensive process for determining where the children are placed.
Okay, I just know that when we had some of the testimonies going around star homes, you use an organization to evaluate placements for you. And I wondered how, if you do that, you must have a definition of what types of services they provide. And if we do place them in a facility that was not originally the first choice, then the responsibility, does that fall on the star home, or does that fall on the agency to address the needs of the child? That's what I'm a little, I'm curious about. Do you
just to clarify, so the organization you referred to, I'm assuming is Carillon, who does apply level of care criteria to assessing what's the appropriate program for a child. And we've supplied in the packet some models of that. Those would be for the treatment program, for example, therapeutic group home and residential treatment center.
Mhm.
Star homes are outside of Carillon's assessment process. So the star home evaluation is within the area office clinical staff. So it's a separate process.
Okay, all right, that answers my question for now, so we'll move on. Okay, thank you. Any other questions from any of the members? Okay, moving on. Question 3.
Question 3 is around how long a STAR staff member would be allowed to remain in contact with any of our children after an alleged assault. Commissioner, I think the answer is fairly straightforward, but if you want to add some context.
Yeah, I mean, I think the answer is there. When we encounter situations like that, we remove the perpetrator from the scene. We pursue law enforcement, and we take action immediately so that there is no threat of future harm from that particular person to the children that are in the STAR homes. So failure to address those issues by the provider results in corrective action plans, and we move swiftly when those things occur. And we have moved swiftly in the past. In every incident, we removed the perpetrator from the home immediately.
All right, any questions? No, moving right along. Number 4.
Number 4 speaks to training in the STAR homes. Commissioner, I think you're going to speak.
Yeah, so the the training that's offered there is nice and clear. As I said, I went through the training programs myself. I mean, since that's my, that's where I spent a lot of my time in the training. I did, we've had discussions about what additionally could be added to the training complement. And so we're under discussion with our program leads about what different things could be added to enhance issues around safety. I even talked with one of the providers about adding questions in the interview process around boundaries, just to see, how the person responds and those kinds of things. So we're actively looking at the current offering of training that they have. As you may or may not know, the Academy has a provider academy that has been established just to create uniformity of training with our providers. And so we're doing a lot to push out training and make sure it's consistent across the board. And we will continue to revisit the training that's occurring in our STARS.
Any questions? I think that's pretty self-explanatory. Thank you. Thank you, Commissioner. Number 5. Are these all Star Home questions?
Just the first few,
Do
Representative.
you guys do anything else with Star Homes?
Doesn't feel like it lately.
I know. Well, this next question is almost akin to your question. How often are the levels of need of Star Home residents reassessed? Do you want to take that, Frank?
Well, it just said every youth going into a STAR, in addition to the pre-placement assessment about where they should be placed, within the STAR home receives a comprehensive formal assessment minimally during the first 30 days, often sooner than that. And then there's the expectation that on at least a monthly basis, the team in the area office and the provider and youth are meeting together to check in on status, to address any needs that have emerged. The feedback that we get too is that there are often mechanisms if there are youth that require more frequent meetings, that certainly occurs. So it's very much responsive to the individual needs.
All right. Any other questions from anybody? No. Next. Star Home question number 6.
This question was related to how many Star Home residents had a foster home placement prior to their placement in a STAR. So we went back to December of 2023. Of the 47 children we've had admitted to Star Home since then, 72% had been placed in a foster placement prior to STAR, and 48% had been in an FFT or therapeutic foster home setting prior to their placement.
Could you just, I don't know if it's in here, but FFT, can you just give us a basic overview of what a FFT or
It's functional family therapy. It's an evidence-based manualized family treatment. And so it's one that we funded for quite a while in the community, but it's one that more recently we've, in partnership with the FFT developers, applied a model to therapeutic foster care. So it's essentially our embedded family, systematized family intervention that is the basis of the therapeutic foster care intervention.
And they have the number of kids that we have in FFT foster care therapeutic. It's approximately what? Do you have an idea?
We have 588 slots in FFT foster care.
Wow. Okay. All right. Okay. Any questions? Okay. Question number 7.
Yeah, let's go see.
So this question is designed to ask how many placements a child might experience while they're in the care and custody of DCF. Commissioner, I could certainly defer to you for context around, or Michael, placement stability rate and the national standard of 1,000 days if you'd like.
Only to say that before Melanie gets into the numbers and the data that's there, we've done actually pretty well in this category compared to the national standards. I think that we have about, 50% less moves than the national average. So this is an area where we have historically excelled. It'd be interesting to see post-pandemic and with the mental health crisis, how that's impacting not only us, but even what's happening across the country. But go ahead, Mel, you can give the particulars.
So we went back to 2020, but essentially the way that the foster care placements are measured nationally is placement per 1,000 days of foster care. The national standard is 4.48. Our standard for calendar year 2023 was 2.23. That is up from where it has been over the last few years. But as the commissioner said, it's still roughly half of what the national standard is.
Questions? Can I ask, I know it's just a question, but if you don't have the answer, if you could get it, how many kids do we have placed outside the state of Connecticut?
5.
Okay, good answer. Thank you. Okay. Question number 8.
All right, so we're moving away from stars, and this question is about our CT Kind case management system build. We were asked what our up-to-date expenses have been, as well as our projected to completion expenses will be. That answer is provided in this grid here. I also wanted to just note that this project is being completely funded by state bonding as well as diverted revenue, as our case management system, if it is CWIS compliant, which it is not right now, that's a federal standard. But when it is, that we are able to claim under Title IV-E for that system. So we're not using general fund money for it. It is 50-50 state bonding and diverted revenue.
Okay, so the project will in total be about 136 million. Right?
Yes, ma'am. Yes, ma'am.
And this is our case management system that you use to manage and facilitate children in care and custody in DCF?
Yes.
Are there any questions from any of the members? Thank you, ma'am.
Okay. There were quite a few sub-points to this question around the data reporting and tracking capabilities of CT Kind. And the answer to everything we were asked is yes, CT Kind will be able to do all of it. There will even be an integration with our provider data management system, the provider information exchange, that will make a link, not to be confused with the case management system we currently have, but will make a link between our provider data reporting system and CT Kind.
Will you be setting up a baseline or a board for people to try and research different data on the kids that are in your program, such as how long they're in foster care, where they how many are not giving any personal data, but a dashboard that gives us data on how things are going in DCF? Will that come out of this project?
Yes, I believe so.
Yes.
Yes.
The answer is yes.
I'm
sorry,
I'm
I was
not
waiting for
your
the
head's
answer.
open down, Melanie, but I'm not hearing anything.
I was waiting for the commissioner to weigh in, but yes, I've seen, we've all seen some of the reporting capabilities in the dashboards, and let me just say, they're beautiful.
They really are.
We like that. We like that. We like
Yeah.
transparency, and we like people being able to answer their own questions as often as possible. So that shows that you're proud of what you're doing. So thank you. I guess we'll go on to question number 9.
So question number 9 was around our waitlist information. And Commissioner, do you want to add some context, or do you want me to just go into it?
I want you to answer the question, I want the committee to understand that we know the spirit of what you're trying to do here. And that is, how do you know when a family asks for a service and they don't receive it, right? And then how are we tracking that? And more importantly, how are we making sure that the service that the family needs or the child needs is what they get and not just an alternative? So I just need you to know that I hear your question, and I believe we answered your question in our response, but if not, you let us know. So go ahead.
So, as we've said before, that we make sure that when a child is referred for a service, if that service is not available, that we find an alternative service. Because of that, the term wait list for us and for our providers tends to mean something a little bit different than it does traditionally. So we thought that it would be more relevant to talk to our providers about the number of referrals they receive. And of those referrals, the ones that went unmet, why? There were at least a third of our providers did not respond in time for me to work those numbers into this response. But as you can see here, of the metrics that we did receive, it did show that for 2023, 6.98% of the referrals made to our programs were unable to be served, either because of provider staffing challenges, that would be 4.58% of that, or because the program was at capacity at the time of referral, that was 2.4%. For this year to date, that would be through January 31st, that percentage is about 10%, so it is just a little bit lower. As the commissioner said, we recognize that this is data that we need to be tracking on an ongoing basis. It cannot be something that's ad hoc. And we are actively working to integrate this as a collection metric in our provider information exchange.
You would be able to, with your new in-kind system or CT-kind system, you'd be able to identify if Tony Walker was referred to therapeutic foster care and she was diverted because of opening to a star home or something like that, you'd be able to identify whether or not that was the first choice, correct?
I do believe the system will capture that at a case level, yes.
So that would take the mystery out of what does it really mean, whether they're wait lists or not. It's just because of availability and stuff. Okay. Questions? Okay, next.
Question 10 spoke to both our internal CQI and quality assurance protocols, as well as our external contracted provider performance management protocols. So there is an attachment that goes with this question that fully defines all of our CQI and QA processes. What I included for review right here is just kind of a snippet. The attachment does go into what each one of these things are and what they do. And then as far as contracted performance management, we have roughly 80 service types that encompass about 330 to 350 individual programs. Each one of those service types has a set of defined performance outcome measures. And the DCF Service Outcome Advisory Committee, we call it SOAC because we like our acronyms. SOAC, it's a multidisciplinary group of DCF staff that are not only charged with the development of performance measures, which would include input from our provider network, as well as our consumers, our clients, our kids, and our families. But SOAC is also charged with looking annually at outcomes for all of our service types, both at the program level and at the service level. So program A had an outcome this, and program B had this outcome. The overall for all 10 programs in that service type is this outcome. And we're working towards right now actively annual performance report cards. We're not quite there yet, but we're hoping that within the next year we'll be able to implement those.
So CQI stands for?
Continuous quality.
Continuous quality improvement.
Just want everybody to have the same alphabet. Okay, so is CQI also similar to program evaluation or quality assurance? That is what you call your quality assurance programs? Is that correct?
It's nuanced, and I don't have my QA person here, but QA generally is quality assurance, and it is, did you do what you said that you were going to do? CQI is the continuous quality improvement, meaning that you're making changes as you go along. It's more of a systemic way of going about doing things versus a checks and balance kind of a thing. Okay. So yeah, so some people use the terms interchangeably, and they're not the same, but they're cousins.
Okay. And I see you have an attachment that you gave us that is that we'll be glad to read later on. But the main point is that you do evaluate your programs and your contracts. Do you do it annually? Do you do it semi-annually? Do you do it every 2 years?
At the contract level, it's annual.
Okay.
And but the CQI, we have program leads that are continuously looking at service provision. They're checking with compliance, the contract. They're looking
providers.
Meeting with the provider. Go ahead.
And each service type. So, for example, the outpatient clinics, the program lead for outpatient clinics meets with the providers regularly to talk about any issues or implementation issues that are coming up, provider needs, extended day treatment programs. They meet with the providers. So it's ongoing, real-time addressing any issues that come up, as well as utilization, and barriers to utilization, in addition to those sort of post-hoc assessment of contract compliance.
I left the Star Home and looked in the sign-in book, and there was the PDOC. Had been to that Star Home, earlier that day.
Another aspect of this too, just to kind of give some broader context to that, our licensed facilities, our program leads visit them quarterly, and they issue reports, and those reports now are posted on our website. We have a licensed facility website that the public can go to and review those quarterly reports.
Okay. So we are evaluating the systems, and the attachment that you gave us is what you evaluate the systems on. Is that correct?
That attachment is what we evaluate internally.
Okay, was that different from what I said?
It's a little different. So I think you are asking about our contracted programs. The attachment is specific to what our internal efforts are around the work that our staff do.
Okay, so then maybe I should ask this then. Do we do quality assurance for our contracted services?
Yes, so that's what Dr. Gregory and Vinny were just speaking to. Yes.
Okay, so
there's just that's just not in the attachment, Representative.
Oh, okay. Can we get a copy of what you do for your contracted services? I think I believe when this question was asked, it was more about how you evaluate contracted services that you
Got it. We can get that to you. No problem.
Yes.
Thank you. Administrator Susan Keene, that's the person. She's the lady. Okay, thank you. Any questions?
We'll look everything sent to Sue, any additional stuff as well.
Yep, we got it. We'll send it to you, Sue.
Thank you. Okay, number 11.
We were asked to provide a breakout of our behavioral health funding by DCF account, which we did here. I do just want to point out that we don't distinguish in our funding. We don't distinguish between our behavioral health mandate, so voluntary children who are receiving services, versus children in DCF care and custody. So when you look at this $141 million amount, which is all state funding, it does serve both kids in our care as well as kids that are being served under our behavioral health mandate.
Okay, so it's all, again, it's then all,
Our slots in our contracts aren't broken down. So for example, in our outpatient psychiatric clinics, we might purchase, I'm making this up, we might purchase 25 slots.
Okay.
Those 25 slots, it's not reserved, 12 for the community and 13 for DCF.
Got it. Okay, I see what you're saying. So it's blended. It's a blended slots for both DCF and for community services.
Yes, ma'am.
Okay, all right. I'm not sure if people were trying to find out how many are available in community services, and that might be something that that they were asking about. So maybe if you can try and break it down so that they can understand how many community service programs are out there available without having to be specifically under behavioral health. I think that's what that might have been. So that
I would say, just to follow up on what Mel said, with some exception, like board and care for foster youth, but that would be DCF kids. But for the most part, all of the community service behavioral health contracts, outpatient clinics, extended day treatment, multi-systemic therapy, et cetera, are available for youth in the community, irrespective of DCF involvement. So it really is, if you live in Greater Waterbury, here's your program. If you live in Greater New London, here's your program. Emergency mobile crisis services, all of that. So for the most part, the majority of the community behavioral health service contracts are available to all.
And we've been very purposeful in structuring our contracts to say that they'll take clients on an as needed triage basis, so that we're not prioritizing one above the other. It's the ones that are in the most need if we reach a capacity issue.
And I would venture to say that is one aspect of the way we do business that actually sets us apart from a lot of jurisdictions. Because there's no sort of wrong door, like anybody could have access to these services, and we contract that way, which made our family first process a little bit difficult because we were so far upstream where that was concerned, that it was hard for us to get, even go even further upstream, because we were already ahead of many jurisdictions because we were providing our services in this way.
Okay, I hear you. I think maybe some of my colleagues were concerned because of if family supports, let's say family supports has 50 slots, and all 50 slots are already occupied by kids that are in custody of DCF, what is available for the community outside that are, I think that's where the question, but I'm not exactly sure if any of my colleagues want to pipe in, because I'm just trying to interpret. I see Representative Gilchrist has a perplexed look on her face. No, okay.
Just try to follow.
So I think that the being able to see how much are occupied by kids of custody versus people who are looking for services for families without having to be in custody of DCF was part of the question. So
maybe we could look historically to see what it has been, the breakdown has been, and give it to you so you can have a sense.
We can.
Okay. All right. Okay. And if we need more information, we'll let you know. Okay, going on. Thank you. Question 12.
So question 12 was around the estimated number of children in Connecticut with significant mental health or behavioral health disorders. According to national prevalence studies, that is estimated at 20% with a behavioral health condition, with another 10% who would meet the criteria for serious emotional disturbance.
Okay. Okay, so that'd be about 30% total?
Dr. Gregory, I'm not sure if that equates to 30 or if the 10% is part of the 20.
It's half of the 20.
It's within the 20.
Okay,
So it's 20%, and of the 20%, 10% have the serious emotional disturbance.
okay, okay, all right. Okay. Moving on. Question 13.
We were asked to provide data of the number of children who are in our care and custody over the last 5 years, which we have done here. Blue indicates our foster care caseload. The reddish orange is our services post-majority caseload. It is not, these numbers are not inclusive of cases that are still under investigation, or any of our in-home cases. So a case that is open with DCF, but the child is still residing in their home.
Okay, okay. All right. No questions there. 14.
We were then asked how many children over the last 5 years we have served who are not in DCF's custody. That would be our behavioral health population. So again, it does not include children with an open DCF case, but you can see these numbers here.
Representative Statham.
Thank you very much, Madam Chair. Thank you for this. I think it was one of the questions I had been thinking about. So for fiscal year 24, do we see that 30 tracking in the same line as fiscal 23? Is there any sort of seasonality to these cases, or, my thoughts were a lot of programming happening during summertime. So if these are people who are served by other programs that are not in care, maybe those would be picked up in the summer months. Do you mind talking a little bit about that and what you're expecting for fiscal year 24, and what your sort of views are overall? Are the number of people getting served increasing, or are they decreasing?
I'm sure I could speak to the number and then let Frank take the context.
Mm-hmm.
So our projections right now, we're projecting about a little over 51,000 for FY24 in totality. So that is a little bit higher than we've seen over the last few years, if our trends continue to hold true.
And I think that's pretty consistent. If you look the last couple of years, 46 to 49 to 51, it is increasing a bit. I think it would reflect, the question before about, prevalence rates. And I think we're still seeing impacts of the pandemic and post-pandemic in youth mental health needs. So I think that's reflected there.
Do you have an analysis of these by the type of programs they're in, or is that just too difficult? I was just kind of curious where the trends might be in terms of mental health versus other sort of, family domestic violence, or any sort of other sort of program supportive type programming.
We could.
If you do, it's not urgent. I was just more curious to know that, are the programs that we're investing in matching the trends that we're seeing? So it's really the sort of gist of my question.
We could tease that out and pull some of those numbers out.
Yeah. I'm just kind of curious if there is any sort of correlations. Thank you.
Thank
Yeah.
you.
So I just want to be clear, right, your question correct. So you'd like us to break down question 14 by service type, correct?
More curious, in looking at the kids that were served by these sort of programs by sort of type of program.
Themes.
Yeah,
Gotcha.
and really to see that does this do these trends align with where we are in our budget? Are we budgeting in the right areas? Madam Chair, if I'm going down a rabbit hole you don't want me to go down, you can tell me
That's
to
okay.
stop. I'm just kind of curious.
Yep.
Because we are looking at so many programs, and I just want to make sure we're investing in the right places.
I no, you're not going down, because I mean, it's not just here that we're looking at it. It's also when excess costs in education system, our numbers are going through the roof, which is what I'm sort of going, because I know the amount of special ed kids that are being reported in our K-12 system right now, it is higher than it's ever been. And the cost is, and I'm sure that they are translating into DCF because that's where they will turn looking for support. So if we have about 800,000 kids that are in the state of Connecticut, and you're saying 10% of the kids that you had before, if you go back to your other slide of how many kids in DCF care, I forgot, where am I?
20% with a significant behavioral health.
Right.
condition.
So if we have 800,000 kids, I mean, I don't know. The numbers are climbing, and we're having this in education right now, because those are the numbers that we are trying to figure out how to pay for those cases. And if we need to provide more additional programming in those areas to adjust to the kids that we're seeing coming out of the K-12 system, we need to be prepared for it. And I think that's what Representative Datham is looking at, because she's on education too, and she asks these questions all the time, which are really good. Thank you.
You, Madam Chair.
So we would just like a little bit more deeper dive, if you could, on that. That would help us. Thank you. Next, number 15.
Number 15, we were asked to provide data on emergency department visits by children for mental or behavioral health services over the last few fiscal years. The blue line, it denotes the total numbers. The gray line denotes the numbers who were not involved with DCF at the time of the visit, while the green line denotes the numbers of the children who were involved with DCF at the time of the visit. I do just want to point out that these are Medicaid covered children only, as that's the only data that we have available to us.
Representative Datham?
Sorry again, but curious on these ED visits, how long are these kids, like the average stay? Do we have a trend of those by calendar year? Because at least for the Medicaid patients, we don't have anything else, but one of my concerns that, I'm seeing in my neck of the woods is there's just not enough places for these kids to go, and they're getting caught in the ED. And I know it's not just in Fairfield County, but it's a lot of places. And just want to see if we have looked at trends on number of days or time in the ED, trends in that direction.
We do have that for the Medicaid youth, they would define stuck as a youth who has been in the emergency department for at least 8 hours, who is still not able to be transitioned to appropriate disposition. And so Caroline does track that for the Medicaid youth, so we could work with them to provide that.
Okay. Thank you. Moving right along.
Question number 16. We were asked to provide a breakout of our staffing related to our SOLNet centers, as well as our funding. So this first grid speaks to the total positions currently allocated to both, as well as how many were filled on February 15th and how many were vacant as of February 15th.
So I'm happy to say that we have made some progress
And we do have our DAS representative on the call to answer any particular questions that you have. We were successful enough to open up another unit on the PRTF for Solent South. So we're moving in the right direction, but when I tell you turnover is a real issue, it is a real issue. As fast as we get them in, they're leaving, they're bouncing. And as you can see from the difference in the pay scales for jobs outside of Connecticut, outside of DCF, in Connecticut, people have choices now. And that direct service care is something that is just a real issue. But we are moving. It's not like we're not filling the positions, but as fast as we fill them, you know, we have turnover. So it's an issue.
Senator Lesser.
Thank you, and thank you for this answer. Just what can you break down though? Are you experiencing the same for different types of positions? You know, I see that you got all of the 146 vacancies, but I don't, you know, I can't tell whether those are doctors or nurses or social workers or you know, what specific class of folks you're looking to hire, and if you're having the same trouble across all types, or if it's specifically concentrated in one area or another.
Hi,
So why don't we
Senator
have
Lesser. Yeah,
There you
I'm
go.
happy to jump in here. I do have the breakdown on my screen as we speak, and we do find that it is our direct care that is the highest. Our children's services workers across both campuses, we have 27 vacancies, and then nursing is our other highest. We have 13 head nurse vacancies. We have 15 LPN vacancies, and we also have 13 nurse vacancies. So it accounts for a total of 41 between those three classifications. We find that we have some turnover with our head nurse vacancies, as well as pretty high turnover with our LPN vacancies. Our nurse vacancies, however, we've had that existing almost 13 for years. We do find it to be very challenging to fill our nurse vacancies, and we currently have a very small amount of nurses on our roster, less than 10 at Solent South, I can tell you, because most of them do fill the head nurse vacancy spots because of, you know, just more competitive pay overall.
So everyone is a head nurse these days. Okay.
That's what we're finding. Those are much easier to fill.
Okay. And I didn't see anything in the governor's budget that would provide, you know, any indication that there's going to be relief here, anything that the administration is asking for to, you know, hiring incentives, retention incentives, anything to help fill these positions, because, you know, if folks are wondering why aren't there services in Connecticut, 146 vacancies is probably a big chunk of that.
Right. I can tell you that we've been highly active at career fairs, you know, events that are being held locally and at the colleges, and just, you know, doing our best to make contact with the community.
Well, that's wonderful. And I'm sure you are. I guess my question is, are we putting any money to you know, to keep people there, any kind of any intervention to try to actually fill these vacancies? And how much are you, I guess the other question that I think Representative Walker probably asked is, how much are we lapsing because we haven't been able to fill these vacancies?
So I can chime in and say that we have gone so far as to offer sign-on bonuses to incent people to come. What we found is that people will take the sign-on bonus and then leave shortly after the requirement. So that doesn't work, right? So we're working with Office of Labor Relations and, you know, all the folks at OPM to try to figure out what we need to do to, you know, provide other kinds of incentives for folks to come. But I think what we're dealing with is just, you know, a major staffing crisis within these classifications. And so what we're focusing in on is working with schools of nursing to try to create a pipeline for, to fill our vacancies, to grow the profession, if you will. So that's where we're going, because anywhere you turn in the United States, you're having the same conversation.
Right. And to piggyback off of that, our contract allows for tuition reimbursement and career mobility. So, both of those opportunities together you rarely see. And so that's something that our most recent hires have told us is something that they look forward to working here for DCF. And so we've begun to advertise that in greater detail.
Representative Belinsky?
Thank you, Madam Chair. My question is, are we doing exit interviews with these folks that are leaving to determine why it is that they're leaving, and if they're leaving, why so quickly? It doesn't always come down to money. Sometimes there's a work environment that is not welcoming or comfortable. If people are happy in their jobs and understanding what their objectives are, and being rewarded, by praise about the things that they're doing, you can also make some pretty unhappy people less happy, and then they're less likely to ever get happy again. So my experience is limited, in this regard, except that I have a relative that works in another one of our state agencies, and they're having the same turnover issue, and it's sometimes there's more than meets the eye. So are we trying to figure out how we can have a more attractive work environment?
I can answer that question, and I really that's a very astute question, and I'm glad you asked it. I do believe that is a component of the issue. And to answer your question quite directly, yes, we offer exit surveys to every employee who leaves, and then we offer a subsequent exit interview. And we are compiling that data now to really get our arms around, why people are leaving. The overwhelming majority of the people who are leaving are talking about workload. They're talking about stress. They're talking about, work-life balance, wanting to be home with their own kids, because, which is exacerbated in part by some of the staffing challenges that we're having. But I think you're absolutely right. We're trying to get our arms around organizational culture to the extent that we have a person dedicated to assess organizational culture. And we will be distributing a survey so that we can get a pulse on, how staff are experiencing the workplace. Praise, goodwill, a positive environment goes a long way. And a lot of people who come to work for DCF are here for the mission, and because they're making a difference in the lives of children. So pay isn't the only thing. But when you think about the acuity of the kids that we're having that are coming to DCF, and the workloads and the type of work that we're doing, it's a harder job than it was pre-pandemic. The kids are harder, the situations are harder, and we understand that we have a part in this as well to do what we need to do to improve our culture as we deal with the workforce crisis. But you're right, a lot of times we do hear that people are leaving for higher pay, they say it. Closer to home, those kinds of things. But we are concurrently working on what you are describing as our organizational climate.
That's really wonderful to hear. Thank you. I commend you for that, Commissioner. I hear stories from the inside from my relative, and and this individual is a social worker, and and cares very, very, very deeply. You know, this individual takes an awful lot of crap, and just sort of, you know, balances it against the love of her work. But you know, there are days that are trying, and you know, the stress of being in 146 positions is, wow, it's mind blowing. So, but I'm so happy to hear that it's on your radar. Thank you.
Thank you.
Absolutely, absolutely. And I appreciate your comments because when you know people who do this work, you understand the burden that they carry. And it is very heavy. And so we are doing our best to make sure that we do everything we can to support them. And we are holding our own selves accountable, all of our leaders, because sometimes when people get stressed, they get mean. And so we're working on that climate issue. I need you to know that's very near and dear to my heart. So thank you for raising it.
Thank you. And I want to move everybody along because we've got a few more questions and we've got about a half hour, but I'll also throw in there, it's also called Human Resource Consolidation that happened a couple of years ago, but I'm just throwing that in. Question 17.
Question 17 moves us into our substance use work. We do have programs that are dedicated to the adults that take care of our kids, as well as services directly for children and their families. We were asked to provide the services, which we did, to delineate which are which, as well as what our expenses have been over the last few years.
Thank you. No questions, moving right along. Question 18.
Question 18 was geared more towards how many slots we have available for children with substance use disorders right now. So you can see that there are 5 separate service types. Our daily capacity would be 544 slots, and our annual capacity based on average length of stay for each of those services would be 1,245.
And you have bilingual programs in all of these to accommodate the parents?
Every one of our contracts, substance use, behavioral health, or other, require bilingual staff, yes.
Excellent, thank you. Question 19.
We were asked about residential treatment programs for children with SA. Frank, I will just certainly defer to you on this. But you can see that we do not currently have any medical substance use treatment facilities for adolescents.
And just to add that there are some private providers who are coming into the state to open facilities, and with Medicaid, under the Medicaid waiver, there are discussions about, particularly within substance use services, Medicaid being able to fund a portion of those treatment services, distinct from, you know, some of the room and board. So discussions are ongoing, but we, as Melanie said, we don't have any contracted providers for substance use residential service.
I think question A, part A, is very telling. So we'll just leave that for everybody else. Question 20.
Question 20, there are 4 attachments, I believe, that go with this question that have been forwarded to you. But this is related to our residential placement types. What we use to determine appropriate level of care, how many beds we have, our average lengths of stay, and what other metrics that we have. So I can speak to this, or I can pause for questions.
How many attachments were, because I've got 1, 2, 3. Are there 3 attachments there? Are those the ones that?
I believe there should have been, yes, 3. I believe there's 3.
Okay.
This question is just there's 3, yeah, for this question.
Yes.
Okay. Yes, 3, 4 total with all of the
with the question 10. Yes. Okay. Just we will look at that, and if we have any follow-up questions, we'll call you. Thank you.
Okay.
let's see, what, am I skipping?
22?
20.
21.
Oh, I see 20 and 21. 20 has 2 pages. Okay. 21.
Question 21, how many residential beds have we had available over the last 10 years? You can see that in a grid here. The numbers are not inclusive of the Solent Hospital or 2 psychiatric residential treatment facilities. They only represent our contracted or fee-for-service placement options.
It has dropped dramatically.
It has.
Is it that
That's
I'm sorry?
That's reflective of changes in service, namely over this time period, the focus on community-based services and supporting families and children at home has resulted in a decrease in relying on the congregate care placements, both in state and out of state.
You can see a correlating reduction in our boarding care residential numbers.
Senator Lesser.
Yeah, no, I mean, I don't have a question. I have a lot to say, but not a question. I'll lower my hand.
Okay, thank you. Thank you, Senator. Yeah, I think there's a lot of unpacking that needs to be done on that, but we will do that. Question 22.
Question 22 is related to the chair's letter to OPM regarding children with IDD. We are actively, Commissioner, do you want to take this or do you want me to give a summary?
Yeah, only to say that we're in regular conversations now. We have a cadence of meetings that we have with Commissioner Chef around our partnering. We're really looking at statutory authority and resources, and quite frankly, what we've been doing lately is having an agency interagency consultation on these kids, so that we make sure that none slip through. And most recently, we had one with the child advocate present with us to step through, how best to serve these children. And so I just wanted to provide that context, is that part of what we're aiming to do is to make sure that we're working very closely with DDS to make sure that none of the children slip through the crack, and that we have appropriate services to address this population, and that we are nice and clear around which agency serves which kids.
Representative Gilchrist.
Great, thank you. Sorry, to go back to 21 for just a second. Of the 254 children in 2024, or the 355 in 2023, are you able to pull out the data for how many placements, back to that indicator, that those children had? Like, can we see that? So like maybe just I guess just those 2 years. So those 355 kids, what's their average placement rate?
So Representative, this grid is not indicative of number of placements. It's the actual number of beds that were available, not the number of beds that were utilized. We can overlay that.
Oh, okay, that'd be helpful too, to know how many were utilized. And then of those utilized, the placements that those kids had. The number of placements.
The placements within what sort of time frame? I'm just trying to understand.
So back to that indicator, number 7, how many foster, and so I guess leading up to them being in a residential bed.
Oh, I see. Mm-hmm. Got it.
Right, so hi, this is Michael Williams, Deputy Commissioner. If I can repeat back what I think you're asking for, is in maybe in 2023, the number of children that had the placement moves, multiple placement moves. If you want to know how many of those were residential placements? Is that what you're asking?
Nope. So let's take 2023. So in 2023, I'd love to take of that 355 beds, how many were utilized? And then of the utilized, I'd like, if you can, look back at those children. So the children that utilized those beds, and over the course of their involvement with DCF, how many foster placements did they have?
So that isn't a report that exists, but we can create that, I believe, yes.
Okay, that'd be great. Thank you.
Representative.
Thank you. On question 22, you were talking about IDD and DCF involvement. Of the kids that are in the DCF system, how many have been identified as having IDD? And maybe how many of these kids are on waiting lists to get services? Because DDS has you know, a large waiting list. And then I was going to ask the same question about what is the number of kids that are on the autism spectrum that are being serviced by DCF, and how many of those kids are expecting and waiting for services. Do we have any analyses of the wait list?
I would say a couple of things. In terms of the kids in DCF's custody who are either on the autism spectrum or have intellectual disability, their care needs would be provided for by us. They would not be awaiting services from DDS. We would work with DDS to make sure their eligibility has been determined and that, you know, they are in line for transition when it's appropriate. So those youth would, as I said, be our responsibility. I don't have the specific numbers of how many children fit each diagnosis, but we could certainly get that, I believe.
Yeah, I'm just curious, and I'm glad to hear that none of these kids are on the wait list for services. Do you have the same understanding for kids who are being serviced by DSS because of they have autism? Hopefully they'd be getting services within the school system, but they may have additional challenges that DCF might have to face.
A couple of issues, if I may. I think that impact this is, as you can imagine, it's a complex issue. For youth with autism services, for example, who are eligible for the intensive behavioral supports that are available, you know, there are systems issues that impact their ability to access those. Often it's staffing. So, you know, if a child is identified as eligible for that sort of intensive plan, there will be an outreach to a provider to implement that plan, but that provider will then need to identify, hire onboard staff, et cetera. So there can be a delay in getting those accessed. What the question was? Sorry.
It was around kids who are in the autism spectrum being served by DCF.
And IDD outside of. The other issue that comes into play is children who are not in DCF's custody, who have an intellectual disability, who do have concurrent emotional and behavioral health needs, are eligible for our array of behavioral health services. One of the things we are in ongoing conversation about are the standard or typical services in the community, if you will, responsive to the particularized needs of those kids. And admittedly, that's an ongoing conversation. The other part of the conversation is a youth who's presenting difficulties are as a result of their intellectual disability per se, without a broader sort of behavioral health context. Again, admittedly, those are youth who's, you know, the question about who's best situated to address those needs, that does become an issue because they would not necessarily be served by the behavioral health network, but they are typically not identified as eligible for DDS if they're children. So there are systems issues that come up.
Okay, thank you, that's helpful.
Senator Lester.
Sorry, I'm trying to find the mic. Just in terms of the breakdown of services, what I'm hearing a lot is that there's been a significant drop of non-autism related services. Do you have a breakdown of autism versus non-autism services for IDD populations?
Yeah. So services for youth who are on the autism spectrum who are also IDD versus those who are not. Is that
or kids without an autism diagnosis, but who are in the IDD population?
Again, if they are youth who present with a need for broader behavioral health services, they would be in our service count. But in terms of youth presenting with an IDD need specifically, I'm sorry, I'm not understanding that. I don't mean to be evasive.
No. Yeah. We'll submit a follow-up question. Thank you.
Thank you. I just want to say that the thing that really is, I guess, a lot of us are concerned about is, at least I am, because I heard at one point in a discussion with DDS that services for children are not entitlements. It's only what is available. And so I think we're starting to feel the need, and that's why we're happy that you are having conversations with DDS, and we are also trying to get our arms around what services are available and what services aren't. When we start to determine that an agency does not have a responsibility to provide all the services necessary, and I'm not talking about you, so please don't. But it is important that we have an ability to figure out where do we need to go in looking for the appropriate treatments for the population that we are all responsible for. So I think we'll probably have some follow-up questions, but we're running out of time. Okay.
Can I just clarify one thing? If a child is IDD, clearly IDD and autism, that child is going to be cared for by DDS.
Correct.
If a child has mental health issues, they're clearly cared for by us. Okay. If it's a co-occurring situation of mental health and IDD, the primary reason for placement will drive which agency is going to provide services to that child. And it's in that spot where you have a child presenting with both is where we're having the conversations around which agency is best to serve the child. And do we have enough services for that child? And I think that's what you're talking about. And where, sort of who has the statutory authority to actually intervene on behalf. We don't want those children slipping through the cracks, and we want to make sure that there are enough services for them.
Okay. Now, I think that's exactly what we've been saying. And we've also, at least I've noticed it in the JJ system, that a lot of the kids in Manson are well below 70 on their IQs, and that just says that I don't need to answer that. You got that. Okay. Question number 23.
So this was also related to the letter.
Yep. 24.
Yep. Okay. 24 also related to the letter.
Okay.
25. CJTS, the Connecticut Juvenile Training School. So the short answer to what positions supported CJTS in 2023 is none. We don't have any positions that are solely dedicated to CJTS. We supplement with the positions that work at the Solnit Hospital and the Solnit PRTF for basic maintenance and preventative activities.
Okay. 26.
26, asked for the costs for continuing to operate or maintain CJTS in 2023. That was $1.5 million, all accrued from other expenses.
27.
27, we have 3 primary units that are housed at CJTS. Our transportation unit, which does all of the transportation of our children, much of the transportation for our children, as well as their fleet of vehicles. The DCF engineering unit and the IT help desk is based at CJTS.
Oh, you got an IT help desk. Let's hope you keep it.
Wow.
I've got lots of jokes today, okay? 28.
Question 28, similarly to CJTS, what activities were performed in 2023? So obviously our CTU operates out of CJTS, our engineering unit operates out of there, our IT help desk operates out of there. We also use it periodically for large meetings or lean events, and then we routinely use it for simulation training for our DCF caseload carrying staff. We have pre-outfitted rooms that are built out to look like a home environment for simulated exercises. It's actually pretty impressive.
29.
Question 29, our projected expenditures by account for CJTS in FY 24 and 25. And you can see what our projected to year end is for 24 and what our projected for 25 is.
And you've already answered 30.
Correct.
Okay. Thank you. I think that we might have a few follow-up questions and we'll try and get those to you just on the specifics. So thank you everybody for your answers, and thank you team for your questions, and I hope everybody has a great afternoon. Thank you.
Thank you.
Thank you.
Thank you. Are we not
Thank
doing
you.
this?
Madam Administrator, next up we have Department of Social Services, correct?
That's correct.
Okie dokie.
I'll let you know when the commissioner is on.
Okay, thank you. That DDS issue is very serious, very serious. Because there are a lot of kids that are in the JJ system who never got services wherever they were and ended up getting incarcerated.
Mm.
Oh.
I'm just gonna grab one.
Okie dokie. Oh, we got 3 minutes. Take your time. Hello, Commissioner. How are you?
I am fine, Rep Walker, Madam Chair. I'm just gonna go grab something to pop up my computer so my neck doesn't hurt. Okay, hold on.
House Chair had to go get some water, so we got a couple of minutes here. Okey doke, we're all here. Thank you. Thank you, Madam Commissioner. I believe you would like.
Sorry, Madam Chair,
Yes, ma'am.
I was just gonna ask you to hold off for 30 seconds while the rest of the DSS team comes in, but they're now in, so thank you.
Okay. So Commissioner, are we good to go?
We are, yes,
you'd
we are,
like-
Madam Chair, so
Would you
thank
like an
you.
opportunity to talk about something first off before we get
I
into?
did, and I
Go right
appreciate
ahead.
that. All right, thank you very much. So thank you for having us here this afternoon in the working session. Before we begin to review the questions and answers in response to those that were raised during our appropriations hearing, I would like to clarify the testimony that I gave around the cost of the DPH policies and proposed regulations, because there was a news article that was printed that many people had seen. It didn't necessarily tell the full story, and I also should have provided much more detail during my testimony, so I apologize for that. So while DPH did in fact share their policies and procedures with us, we do acknowledge that we could have done a much better job on both sides of the aisle with our agencies in determining what the fiscal impact might be with the staffing 3.0 staffing ratio rule. We did initially share, DPH did share those policies and procedures publicly, and they were shared at least 3 months in advance of the time that they became effective. And the ways in which they were shared and the way that it was implemented was in pursuit of the intent of the statute. So what had happened here was that DPH did let the industry know that it wasn't immediate, it was not going to be strictly enforced, so that the facilities would have time to get into compliance. We at DSS then provided a survey to gauge those costs. So the $55 million that I cited was really an estimate from the survey. That doesn't mean that every single nursing home is going to incur the same kinds of costs, nor does it mean that will be sort of the actual cost at the end. So nursing homes can request cost reimbursement based on the reasonable costs that they've incurred during the 10-month period that those policies were in effect, and that number is being calculated now, but we do estimate that it's far, far lower than 55 million. And that is really what I should have said during the hearing. I'm sorry I did not have all of those talking points with me at the moment. I apologize. I have apologized to Commissioner Jatani and her team as well, but I wanted to make sure that I had the opportunity to raise those clarifying points now and to offer my apologies for not having them available at the time. So that was it. So thank you very much, Rep Walker.
No problem. We all have a stumble in this fall because there are a lot of figures and things going around, and sometimes it's okay. But anyhow,
Madam Chair, that was all my questions were about that, so I guess I can go now.
Forget it, Senator.
All right. And so with that said, and again, thank you for giving me the courtesy and the grace to do that. We would like to turn to the document that we provided that are in direct response to the requests that were raised during our appropriations hearing and provide those responses. So I'm going to ask Dave to share the memo in case there has not been an opportunity to review it. I know probably not everyone has done that or had the opportunity to do that, I should say. And we'll just walk through it one by one. So first we were asked about, all the boxes are obstructing my view, so I will move them so I can see. We were asked about some of the cost estimates in the rate study itself and the potential rollout plan. We did speak to the rollout plan during our testimony, and that in fact was that we were going to engage in 6 weeks of stakeholder engagement so that we can determine what the best use of the $7 million in state share that we have. And that continues to be the rollout plan. The rate study itself and the document, if you have it electronically, does have a link to pages 13 and 14 of the rate study. And it does provide some specific estimates in some of the costs. So you can see them there for autism, behavioral health, and so on. So these are the areas that were actually covered by the rate study. But the caveats here are that these were set at a benchmark that we used that was for illustrative purposes only. The most important parts of rate analysis and rate study really have to do with many of the components that we talked about during our testimony. And that really is the stakeholder engagement, where we stand with respect to other states. We did our five state rate study here. but we can also gather some anecdotal information from other states and where the providers and other key stakeholders and advocates would feel that the number needs to be in order for us to Senator Lesser's point, to make sure that we have the access that we're looking for. So I would really, I would think, ask very respectfully that to be cautious about using these numbers as sort of the final numbers of where we would land if we had the resources as a state and we know what our budgetary circumstances are to look to make any specific fiscal changes, but we did want to point these out and summarize them in the report for you because they are within all different, they're throughout the report on different pages, so we thought having them all in one place might be helpful. So the second question was with respect to the ambulance providers in the interim before making decisions on the rate study. We do know that the ambulance providers did in fact ask for an additional 20% increase in this most recent session. And again, speaking to the budgetary constraints that we have and what the governor's budget recommends, that is not included in the budget in the governor's recommended spending plan in this year. We are still strongly suggesting and recommending that along with all of the other providers that will be studied in phase 2, that we do wait to have that phase 2 study completed before we make what we hope will be very planful and reasoned recommendations as to where ambulance rates and other provider rates should be set in the context of the larger and broader process of rate setting that we would hope that this study would be just one part of, as I'd mentioned before. So moving on to question 3, to provide an explanation in the fluctuations of the SUD waiver estimates. I actually think I saw Bill Halsey, and I'm going to ask him if he would respond to this. Yes, thank you,
Yes.
Bill. Yes.
Hi, good afternoon, Bill Halsey with DSS. So we have a substance use disorder demonstration waiver in effect right now. And what we did with this waiver is we made a commitment from the very beginning that if there were additional revenue above and beyond what we spent within the substance use disorder treatment service area, that we would hold that in a reserve account and reinvest that back into the substance use disorder service system. So the reserve account acts as kind of a holding account for any additional revenue that is not accounted for. So for example, when we started this project, we increased rates for residential treatment providers. And we did not expect a large surplus of additional revenue in the very beginning, mostly because the economic driver on this project is Merritt Hall, Connecticut Valley Hospital, the Demas operated state hospital, their addiction wing of that hospital. And they were having pretty significant staffing issues, and their census was quite low, especially during the public health emergency and immediately thereafter. They are now hiring, they're staffing up, their census is going up, and as their census goes up, that expected revenue that we expect in the state will go up. And so what you're seeing now is additional revenue that we're estimating that will go into the reserve account and that we've committed to reinvest back into the substance use disorder service system. Hope that answers that question.
Okay, thank you. Representative Gilchrist.
Great, thank you. And sorry, to go back to number 2, there's a proposal on the table from the ambulance providers to, I don't know the term, but do something through public health where their rates are set in some kind of way. Can you explain that relationship and kind of the impact of if they were to raise something through the DPA under the Department of Public Health, would that force DSS's hand? How does that impact how DSS provides the rate, the Medicaid rate? Oh,
You're muted. Commissioner, you're muted.
I'm sorry, I had thought, all right. I'm not familiar with what has been raised in public health, so I haven't seen that proposed legislation. But it would be preferable if our efforts were coordinated, because you are right. In fact, it would mean that we would have to figure out a way to revisit that issue. And that would be a less than ideal circumstance. So if you wouldn't mind, I would need an opportunity to really explore that a bit more and then get you a more substantial answer.
Okay, that'd be great. 'Cause
Okay.
something like they determine some level. So yeah, it'd be
Yes.
that conversation.
Yes, it does, but it's still all impacting the governor's budget. And I think that really is the part that we would need to coordinate, whether it comes through a recommendation that we make to hold the rate steady, or, a recommendation that DPH makes to adjust the rates based on the bill in front of them, or I'm sorry, that public health would make. It's still the same impact on the same budget. So I'd like to have an opportunity to explore that a bit more.
Great, thank you.
Okay, certainly.
Go right ahead. Any other questions on 1, 2, or 3? Okay.
Great, thank you. So then we will move to the proposal to move members from Husky A to covered CT. The question that was posed was really why are we doing this, and what are the differences, and what would people gain or lose from moving from Husky A to covered CT? So many, many thanks to Guy Woolston and his team and some other folks at Yale that really helped us to put this together, so that we thought that having the chart might be a very helpful way to have a point of comparison. So we hope that you find this to be a helpful tool. You can see in almost every instance that there is coverage both in Husky A and covered CT. The significant differences that you can see here are in long-term care, where we don't offer that under covered CT, and that's because there's an age limit of 65 for covered CT. But we do have some statistics that Deputy Commissioner Hadler is going to speak to a bit in terms of ways in which those members can still access some form of long-term care through other parts of Husky and Medicare as well. But what is also advantageous is that while Husky A does not provide coverage in a broader context for out-of-state providers, I'm sorry, covered CT does. Covered CT does. And you can see that in some instances that it's not limited in the way that it is under Husky A. So I know those are the two specific questions that were answered. And Dave, if we could scroll down a bit more to the second part, thank you very much. Again, we can see that there are more parallels in coverage between the mental health and SUD and OUD treatment options and availability of services, along with prescription drugs. We can also see that there's a difference here with respect to what's offered under Husky A for infertility services, but those services are in fact available under covered CT. There is another difference here, as you can see, that under Husky A, there is broader coverage that's available for, what we call DME, durable medical equipment and medical supplies. There is somewhat of a narrower availability of these benefits under covered CT, because it does exclude wheelchairs and other kinds of DME, glucose monitors, and other kinds of supplies. And that is based on the design of this particular plan. There are also reproductive services that are available under Husky A, but we pay, because we know that it's Husky, we pay those with state funds only, because we know the federal restrictions in paying for abortion care. But under covered CT, those are covered. Those are primarily the differences between the two plans, and we were hoping that a side-by-side comparison with the categories of coverage would be helpful. And we're here to answer any questions that you might have, because I know that this one was of particular interest during the appropriations hearing.
Great, thank you. Senator Lesser, go right ahead.
Yeah, this is fascinating. It's actually the first time I've ever heard administration acknowledge any differences. So this is actually super, super helpful. And I was wondering if you had, beyond our, colloquy during the hearing, just wanted to see if you had looked at, I guess perhaps with the exception of long-term care, if for the other services you've discussed, for example, wheelchair services, if you've looked at whether it would be possible to do some sort of overlay for the covered Connecticut universe to match at a minimum what's available on Medicaid.
Yes, so I'm going to ask Guy and DC Hadler if they would speak to that because I personally have not done that. We did do a little bit of that with the long-term care because we do know that that's an extremely, not that the wheelchairs and the DME are not, but uh, we did anticipate, I should say, that there might be some more concerns about Husky members losing long-term care. But Guy and Deputy Commissioner Hadler, did you have anything more that you wanted to add around the DME and the medical supplies?
Great, I can definitely chime in. Thanks for the
Thank
question,
you.
Senator. And before I directly answer the question, I do want to just underscore what the commissioner said, which is there's a lot of green on the chart. There's a lot of overlap, and that's by design, right? There are some differences, and I definitely want to acknowledge those, but the overwhelmingly Covered Connecticut was designed to mimic, and in some cases, be more generous than Husky. On your specific question, in principle, we could add to the covered CT, one could add to the covered CT benefit a wraparound program like we did with dental and non-emergency medical transportation, right? To try to make the covered Connecticut and Husky benefits completely parallel. That obviously has some expense. There's also some administrative effort of that. So without getting too far into the weeds, it's been a pain and fairly expensive per member served to add on the kind of the dental and the non-emergency medical transportation. I'm not saying it's bad policy, but I'm just trying to give you insight into kind of how the sausage is made. That would also require amending our 1115 waiver with CMS to get them to cover those additional services. So in principle, one could do it. I think that the question is whether the cost and the administrative effort is worth the difference in benefits, and that would be up for you all to decide.
But you could help us cost that out.
Yes, I think we could. What we could do is we could look at current Husky A population and how much they spend on these services today, and that would give us some sense of utilization and also on cost. If you heard a little bit of hesitation in my voice, Senator, it's just it would probably be an extrapolation and estimate for right reasons I can get into if you want, but I think we could definitely do that if that's of interest to the group.
And I think certainly for NEMT, we've seen decreased utilization for the slightly higher income folks on the covered Connecticut population. And so I'm wondering, especially for things like wheelchairs, I'm guessing that a lot of folks who are on wheelchairs don't have any, I don't know this, I'm just guessing that a lot of folks may have no income or very low income, and so may not be as high population in the sort of the little bit of a higher tranche that you have on. I'm just guessing here, but I'm just in terms. It may not be as bad as we think potentially, but I don't know that if that's the case.
Yeah, good question, Senator. We have not pulled that particular data point, but it's something we certainly could pull.
And if you could help us cost out, I assume we have a bunch of options, but one of them could be carving out long-term care altogether, and perhaps not. I don't know if that's I don't know what our options are for long-term care, but given that that's where we had the biggest pushback so far. I don't know if we could move one population but keep long-term care on Medicaid, or what our options would be. I don't know if you could help us sort of. That could be for you, Guy, or for the commissioner to sort of help us understand what our options and what those various costs would be.
Yeah. Thank you, Senator. If you don't mind, I'm actually going to ask Deputy Commissioner Hadler to talk about how we might fill that gap, because that's obviously been a source of quite a bit of discussion here. So, DC Hadler, if you're there.
Thank you. Yeah, Commissioner, and thank you all for the conversation. I think as Guy has sort of highlighted, right, we can go back and look to see what it might take to do some wraps around Covered Connecticut, like we've done for dental and NEMT. But more than anything else, I just want to emphasize that actually the number of people that we're estimating that are in this income band and accessing long-term care services is extremely small. We're currently estimating that there might be 22 people accessing long-term care in this sliver of the population. So again, an estimate, but one that is borne out by the overall utilization data related to long-term care in Husky A in general. Of course, Husky A is not the traditional path for accessing long-term services and supports. There's many good reasons why long-term care is generally accessed through the Husky C pathway, notably because there are asset limits in that area of the program. And the general policy behind that, of course, is that it is very expensive to provide long-term care. And if a person does have the means to contribute to the cost of that service, it is in the interest of everyone to have them contribute some of that cost. So that is, and I think we've sort of highlighted that here as well, that some of the people who currently may be under Husky A may well qualify for Husky C. And if they didn't, then they could potentially qualify under some spend down and asset reduction approaches. So it's a very small population, and we think that there are pathways, obviously, for people to get on long-term care specific service coverage groups. So I'm going to pause there, and hopefully that answered that. And I see that Rep. Dathan also has her hand up.
Yep, Rep. Dathan, go right ahead.
Thank you, and thank you, DC Hadler, for answering my question on long-term care. So I only have two questions, if I may. First of all, thank you so much for putting together this chart. It is super helpful. One question, and it's maybe me being pedantic, but Husky A only covers up to under age 21 for ASD, and I'm wondering why that is. If as a state we are taking care of folks who are up to 22 through the school system.
I'm going to defer to any of my colleagues, perhaps Guy or someone else who may have better insight into that.
Yeah.
And a friend.
Amy, if you're on, do you want to hop in? I can't tell.
I can answer that if you'd like.
Thanks, Joel.
Joel Nord from DSS. So in 2014, I believe it was, CMS, the federal government issued guidance saying that autism services provided by primarily board-certified behavior analysts was coverable and therefore required to be covered under the early and periodic screening, diagnostic, and treatment services, or EPSDT benefit under Medicaid. And that benefit is only for Medicaid members under age 21. So it's a unique feature of federal Medicaid law. So the state federally the state could have covered broader age, but at the time there was already significant fiscal impact even for that coverage when it was first added about 9 years ago. And so that's why it was limited to the under 21 population. But the discrepancy is federal Medicaid law lists 21 as the cutoff for whatever reason, who knows why.
And Joel, if I might, I just want to add one thing, which is not directly responsive to your point, Representative. I just wanted to make it clear. On the table, the difference between Covered Connecticut and Husky A, we have made a really good faith effort to go through and make that as comprehensive as possible. Medicaid and QHP, they're complicated, and it's possible that we, despite our best efforts, it's possible we've missed some things, but we did our best to give you as accurate a picture as possible. I'm just flagging, if there are questions or things that we didn't cover, please send them our way. We definitely want to be transparent here. Thanks.
My second question, if I may, is around fertility services. Under covered CT, they're covered. Under Husky A, they're not. Do you mind just kind of highlighting what is covered under law, under covered CT for infertility? And is the bill that we looked at last year for infertility would be mirroring that sort of same coverage?
E, did you want to take that?
I will try.
Okay.
And others can hop in. So it's a great question, Dathan. And the reason why I said I will try is I'm not an expert on the QHP part of the world as much as we are in Medicaid. But I think the answer to your question, but let me confirm with colleagues and we can follow up in writing. I think the answer to your question is QHP covers some infertility services, and I think the bill that you're referring to would require Husky to cover infertility services like they are covered in commercial health plans. So I think that would move that line from no to yes effectively. At least that's my understanding of the bill as it's currently drafted.
Yeah, I'll probably ask again in human service public hearing, so maybe when you guys are doing your testimony that you prepare for that question, because I'm very curious to know what's sort of similar, if there's opportunity there. Thank you so much. Thank you, Madam Chair, and thank you, Commissioner.
Great. Thank you, everyone. Seeing no further hands, we can move on to question 5.
Right. So thank you. So we were also asked during our appropriations hearing to respond to the differences that we had with respect to the Husky C income limits and the after income disregards. So the way that we have read the statute that we believed was in compliance with the amount of the budget that was set aside for Husky C is that the 105% of the federal poverty limit had to be inclusive of the earned income disregard. And when we calculated the impact using that particular method, it did end up being within the fiscal appropriations for this particular change. So now we understand that if we raise the limit to 105 first, and then we have the disregards, that the amount that we would spend is considerably higher than what had been budgeted. The way in which we interpreted this language is, as you see in the early part of this paragraph, which is that we really believed that the 105% of the federal poverty level include the earned income disregard. So it was what the percentage you would come to in totality after having done all of those calculations. And you can see in the last sentence there that that expansion would have cost us 20.9 million and 38 million, but it would have an annualized cost of 76 and 151 million after factoring in the Medicaid share. So that it really was our understanding of the budgetary guidelines that we needed to be in, and this is the way that we had usually included the earned income, the unearned income disregard when calculating the percentage of the federal poverty limit. So that is the answer to that particular question. So I understand that there might be Representative Dathan, I know that you had raised this as a specific question as to why did we do it this way, and this is why we did it this way. Deputy Commissioner Hadler is much more of a subject matter expert in this space than I am, so he will also provide some more clarity and color commentary, but that is the way in which we have calculated disregard before, which is why we follow the same formula.
Thank you, Commissioner. I don't have anything to add to that, but we're happy to answer any questions. I mean, I think this obviously is fundamentally, we would like to clarify the statute to make sure that it reads and works in a way, the same way that the intent behind disregards is applied. And I think that we want to make sure that there is a collective understanding of what the budgetary amount that was projected, that the way we understood that the statutory language aligns to that intent.
That's right.
This is in a way us cleaning this up to clarify and specify that this is the change that amount of budget would cover, and if there's an intent to significantly expand that, then there would have to be a corresponding financial support for it.
Great, thank you. Question. Oh, Lucy?
Yeah, sorry, I was just kind of following up on that with if we can get our sort of, I don't know if we need to get our sort of LCO folks to really interpret this, because, I'm reading it differently and I really understand that the budgetary impact is huge and it's above my pay grade, but this is something that's, as the commissioner said, this is something that's near and dear to my heart, so.
Great. Okay, thanks, Lucy. We can circle back.
And if I may just very quickly just chime in, we have put clarifying language in there that we think brings it into line with intent, as opposed to the language that was passed in the last session. So there are two things to be able to compare, and we're happy to answer questions about that.
Great. All right, I don't see any other hands. We can move on to
Question 6. So here, the one pager is embedded. Apologize for that, but we can just see if we can get that open for you. I don't know, he's going to try. Dave, if not, exactly, he's going to try to open it in a separate document so we can review that for you. There we go.
Sorry about that.
That's all right. See if we can get that specific document opened. All right, here we go. Terrific. If you click on it, it will work for you because it did work for me. And if it doesn't, please let us know. We'll send the document as an attachment. We have actually been doing exceptionally well when it comes to public health emergency unwinding, and particularly when compared to other states. You can see here that we have our re-enrollment rates, our passive renewal rates, and our procedural termination rates as compared to the nationwide average. And throughout all of the months that we've been measuring these rates, or we started with our unwinding, March, April, actually, the PHE unwinding was actually wound down officially on May 12th. You can see that our re-enrollment rates are in the high 60s and low 70s. In September, we actually were close to 79%. So in October, we were at 81%, which far exceeded the national average. The same is true for our passive renewal rates. You can see that in October, we had a passive renewal rate of 72.8%. And the passive renewal, for those of you that might not be familiar with that, is a renewal that can happen essentially without the Medicaid member doing really much of anything, quite frankly. We use all of the data that we have available from other state agencies and federal data that we are allowed to access through agreements with the federal government. And we just use that data to just automatically renew an individual and re-enroll them in Medicaid. So the procedural renewal rates, you can see in October, we did have some challenges there, but for the most part, we have been at or above the national average with the procedural termination rates. But actually, I'm saying it the other way around, which is that what we want is a low procedural termination rate. So that we have the other way around. So you can see that we actually significantly improved our procedural termination rate in September and October. We were right around the national average, well below in some instances, you can see in May and in June, but we really made a significant concerted effort to make sure that we were reaching out to people, that we were letting people know. We used social media, we used mailings, we used all kinds of things so that people would know you really need to come in and be part of the two groups above here, the re-enrollment rate, right? Call and actively renew, or you've been passively renewed. We used every available means that we had so that we could really keep our procedural terminations rates low. So these are really the people that we could not reach no matter what we did. Every state has some cohort of Medicaid members that are in this procedural termination rate, meaning that they just, for some reason, did not re-enroll. And so because they didn't respond to us in the period of time that we had set, and we didn't have any passive renewal data or re-enrollment data from them directly, we then ended up terminating their coverage. It's really hard, really, to kind of dig down and figure out why that happens. It happens in every state. It's really hard to find, the tens of thousands of people from state to state, but I think the efforts that we've put in have really been able to drive down our procedural termination rate. So this is essentially how our unwinding status unfolds over these last few months and where we stand with respect to the national average. And we are among the top 5 states in the country in these key metrics.
Fantastic. Thank you. I was going to ask a question, but I see after Rep. Dillon, Rep. Johnson raised her hand, and I think I was going to ask it on her behalf. So I'll wait.
Okay.
Rep. Dillon,
Okay.
but thank you. These numbers are great. Rep. Dillon and then Rep. Johnson.
Jillian, you were asking it on my behalf or Susan's?
Susan, so go right ahead, Pat. Sorry about that.
Great. We both have lots of questions. I think Susan usually wins that. So on the people, we did have a number of people in the beginning of the unwinding, who it seemed to me were getting kicked out for procedural reasons, or not things that were cleanly eligibility. Would that be an accurate statement?
I would say that in the beginning, every state was experiencing that. So yes, in a very broad sense, that is an accurate statement, because although we did an enormous amount of outreach, we had a campaign, contact us so we can contact you. We still had a fairly high procedural termination rate in the beginning, but every state had been experiencing that. But what happened was, as we continued to engage in our outreach and engagement efforts, we saw people coming back in. And so that's where you can see the correlation between these rates coming down, right? And you can see the passive renewal and the Connecticut re-enrollment rates going up. because then people realize, oh, wait a minute, I am still eligible, and I hadn't contacted DSS, or I hadn't responded to the 3 letters that I thought were junk mail, and I never opened them, and then I opened them and I realized, wait a minute, I should be re-enrolling. So we see people coming in and out all the time. This is DC Hadler tells me this all the time. It is the nature of how Medicaid works. So when we see our re-enrollment rates and our passive renewal rates start to tick up, we think that's a very good thing, because that means that we're getting to more people who had been procedurally terminated and are now coming back in.
Okay, yeah, well, one reason a lot of people prefer presumptive eligibility is some of what we're talking about. But
yeah,
so if I understand you correctly, and I want to make sure I do, because we're jumping around to different meetings today. Would it be fair? What would you say happened to the people who didn't make it in the beginning, understanding that we were not an outlier, other states had problems? What
That's
happened
right.
to those people?
So thank you, Ripton. I respectfully, I don't know if I'd necessarily characterize it as having a problem. I think in the beginning, people were still really trying to understand that the unwind was actually happening, right? So, but I don't think a lot of people really understood, oh, wait a minute, I hadn't really talked to anybody at DSS for, close to 2 years, because everyone just remained enrolled. So there was a learning curve with respect to those who had been enrolled. So once that learning curve, I think, started to have a downward trend, then we were able to get people either passively enrolled or in the re-enrollment rate. So I don't know if that really answered your question, or I'm sorry.
I may be misunderstanding the process.
Okay.
I'm not sure.
Okay.
But let's say someone did not re-enroll in the first 3 or 4 months.
Yes.
What happened to them? Was there a deadline by which they had to get back in? And
No.
maybe perhaps I should know this. And
Oh, I see. I understand your question now. I
what
apologize.
happened to the people who
Yes.
didn't make it in the
Yes.
beginning?
In the
No false discussing, just
that
where
now
did
I
they go?
understand. Yes.
Okay.
Well, there are several categories of people that fall into procedural termination. They may not have responded because good things have happened. Maybe they or a partner in their home or it has got a really great job, and so now they have insurance, and they don't need this anymore. So we do have a category of people that cohort of people that fall into that category. We have people that have now gotten terrific jobs and they no longer qualify for Medicaid, and they make their own decision that they're not going to reapply. But if they determine 4 months from now, oh my gosh, you know what? Wait a minute, I do qualify. Maybe I didn't think that I did. They can come in at any time, and they have been coming in at any time, and that's where you see it. That's why I was pointing to and I'll point more specifically to the re-enrollment rate. Those people can come back in once they realize that they kind of missed the initial entryway in April and May. They are not precluded from applying.
Well, your scenarios were much more optimistic than mine. I was thinking, oh, maybe they got evicted. Maybe there's domestic violence. And
those things are true as well.
Many reasons for being in a different
That's correct.
Place.
That is correct.
Now, on this particular category, your agency, Connecticut is one of the 20 states that use Deloitte. Is that true? As a consultant on certain things?
Yes, I mean, Deloitte is ubiquitous in many states. Yes, we do use them. Yes.
Now, there is litigation going forward from one of the national health law groups concerning Deloitte's algorithms. I think it's probably Texas they're suing. Have we looked to see whether, since there are 20 states that use Deloitte, have we looked to see whether there were any problems with any algorithms related to the work that they did for us?
I don't recall.
I don't know if you're familiar with that case.
I am somewhat familiar with the lawsuit. I have been seeing some of the headlines in it in some of the trade publications and some articles that have crossed my email. So I have seen that. No, we haven't necessarily had that level of challenge with Deloitte. When we get data, we probably need more data people than we have. but we have a sense from our own history, really where we should be and what the data may be telling us where people are. And then that is really what guides us with respect to the degree of outreach and the expansiveness of the outreach that we would want to do. But in this instance, we haven't had that particular impact that Texas has had. And actually, I'm going to ask Deputy Commissioner Hadler if he would come off mute and just add a little bit more as to how we use the data and what it is that we do with respect to having that data sort of guide our work in determining how much outreach we should engage in.
If I could pipe in, and also whether or not you've seen the case that was filed, I think it was the 27th, I don't remember, about the algorithms that Deloitte uses, if you know
Thanks.
that.
Yeah, no, I'm happy to sort of chime in here. I just want to very preliminarily note, right, that Deloitte, like other large vendors, does support many states. They help to design and build some of our eligibility systems. However, every state has the opportunity to customize and review the processes independently. And I think you'll see from the data that is being shown up on the screen, you know, how Connecticut is routinely ranked in some of the top states in the country for both passive renewal rates and re-enrollment rates. In contrast, Texas has been at the very bottom. And so I think that that's probably why that particular lawsuit has been filed. You know, there may be a contributing factor of the way that the system has been programmed in consultation with the staff at the Medicaid agency down in Texas. But, you know, the way that our system is working, and they're not all identical, but ours is working quite well. And we have been able to even improve during the unwinding process, which is something that we're happy to be able to say, right? We've continuously improved. And that was in collaboration with our partners at CMS at the federal level. So I think we feel quite confident in where we are. You know, that we have had challenges along the way, like every other state, but we've been able to address them promptly and quickly. And overall, I think the performance shows that.
Well, that suit was filed as we were in the throes of some fairly intense budget hearings. So I can't say that I feel comfortable because I haven't had a chance to review that case, and it would mean a lot if we could make sure that Connecticut has no exposure in that regard. But otherwise, thank you very, very much for your answers, Commissioner, and thank you, Peter. It's always good to see you.
Likewise. And may I just add one point that you had mentioned, Representative Dillon. You were wondering what happened to some of the folks who didn't leave. I just wanted 42% of all the people who are in this termination group, as noted in the chart on the screen, have actually re-enrolled in Medicaid. So there's a very significant portion of people, which is, it's not the happiest path. We would love for them not to get to that closure point, then to come back on, but they have been able to come back on without a gap in coverage. And so that's another piece of the good news, and is also borne out by the fact that we've actually seen an increase in our Medicaid enrollment between August and December.
Thanks. I kind of start out with kind of a Saving Private Ryan kind of mindset. So if there's anyone that got lost, I'd want to make sure that they're covered. But I appreciate the comment. Thank you.
Thanks, Rep. Dillon. Rep. Johnson, go right ahead.
Oh, thank you so much, Madam Chair. And thank you for these excellent figures and your good work. I'm really pleased to see this and see where we place nationally. It's excellent. I do have, just to follow up on Rep. Dillon's remarks, just a little bit of a question. She did ask some of the questions I would have asked, but I think that I'm wondering in terms of sometimes, as you mentioned, some people might be off of the straight Medicaid, but might be in the Affordable Care Act. And I wondered if that is part of the data that you're tracking here.
Easy. Yes.
Yeah. So that is something that we do track. I mean, we sort of see it in a corollary, right? We sort of see the increase in covered Connecticut. We're seeing that. We're seeing an increase in the qualified health plan enrollment, which hit its highest mark during this last open enrollment period compared to where it's ever been. And yes, a proportion of that are folks who are enrolling in coverage. Our partners at Access Health helped conduct a study about where the folks are going. And as the commissioner mentioned earlier, there are a significant number of people who have found other coverage through the commercial market, through employers. There are populations who have moved to Medicare and are no longer eligible for some of the coverage that under Medicaid. So there's all these little pockets. Some have come back in. Some have gone to Cover Connecticut. Some have gone to other qualified health plans. Some have found summer coverage. So it's an interesting set of information. It's borne out by similar surveys that we've seen from other states that have been shared by our national organizations. It's a complex picture when people leave Medicaid, the reasons and rationales why and where they go to. So it is really a little bit of all of the above, but I'm happy to say that we've got a pretty significant portion who've come back in and requalified too.
Excellent. So the follow-up question to that is, as you mentioned, and my next question was, as you know, when someone qualifies for disability and they've been deemed disabled by Social Security for 2 years or more, they would be qualified for Medicaid as well as Medicare. Is that data in these figures here, or is that? I just wonder where the Affordable Care Act data is, where the transition from the straight Medicaid to the subsidies for the Medicare Savings Program is in this situation, and if that's tracked here or is that somewhere else in your data?
That specific data set is not going to be in the data that's up on the screen. And I don't think it's also actually going to be in some of the more comprehensive data sets that we've got linked to in this one pager. It's a very interesting question. We do have some information I think we can provide. Let me go back and see what I can find about sort of trying to track the number of people who've transitioned to coverage during this process. I think we may have that. It's not something we're required to report to CMS, but it is something that we may have in the data that we've been collecting along the way.
Excellent, because I do hope that we're able to track all the different groups, and that way we're really going to be able to get a handle on some of the problems I see in my district with respect to the difficulties with some people having when they try to make an application for Medicaid. They seem to have difficulty going through that process. So thank you so much for your work, and these are great figures. Thanks so much. Thank you, Madam Chair.
Thank you. All right. Yes, thank you for pulling all this and for the work you've done. We can move on to number 7.
Dave is going to return us to our document. There we go. All right. I think he's almost there. Oh, there we go. Almost seamless movement there. So number 7 was a response for us to provide the number of appeal referrals to the Center for Medicare Advocacy within the last 5 years, how much we've recouped, and the number of staff that work on those appeals. So this is just a chart that is directly responsive to that. That area has 5 people that work in it, 1 supervisor and 4 associate claims examiners. We did have a couple of vacancies. We were able to refill those. So then this unit now is fully staffed. But you can see here, that the trends are such that we're usually around the $4,000, close to $5,000 mark. We did have a bit of a bump there in 2021. And the amount of monies that we have, the recoveries that we have to DSS are also here as well. If anybody had any questions about these, that I think we can try to answer them.
Yeah, sure. I have a couple questions, if that's okay.
Certainly. Sure. Yeah, we have our director here, John Jakubowski, who can answer your questions as well.
Sure. The first question would be, you have skilled nursing facility referrals. Do you know if they're from Medicare Advantage plans, as we might have discussed before, or regular Medicare fee-for-service plans, maybe perhaps with people who are in the Medicare fee-for-service plans that are part of the Medicare Savings Program?
Yeah, John. Yeah, I don't know that, but John.
Yeah, I don't have that answer right now, but I can definitely bring it back and gather that information and definitely, answer your question.
I think that it's really important for us at this point in time, especially where we have the Medicare Savings Program and have the Advantage Plan people who are working to enroll people in the Medicare Advantage plans to be able to track that, because I've seen in my district more than once where the Advantage plans limit access to the networks that should actually be available to them if they're just straight Medicare savings. So they join up for the dental, the visual, the hearing, and then they find they can't get the regular straight Medicare that they're supposed to get. And then they're also denied coverage when they're getting long-term care skilled care in compliance with the definitions for Medicare coverage. So these are the kinds of things that we're running into, at least where I see it in my district, and I get calls from out of my area as well to help people with these things. So this is I think we need to bring this more to the forefront and look at how we manage that, because giving the chances to the private insurance, they're not really insurance, they're trust funds under the Medicare Advantage plans, giving the trust funds the chance to limit access and yet collect premiums is a real problem. So I hope that we can make sure they are providing the same services that would have been provided with just a straight Medicare savings plan.
I'll definitely take that back to my staff and gather the documentation, the information for you.
And by the way, I'd be glad to sit with you for a minute and just, rework the information so that, fully get what I'm talking about, because it can be confusing when you're going back and forth between these programs. And when you already have coverage under the Medicare Savings Program, and to have the insurance industry plop on top of that, and then create a situation where the person isn't eligible when they should be, is a real difficult situation. So thank you for that.
No problem.
Great, thank you. Any other questions on this one? All right, you can move ahead.
Great, thank you. So for question 8, I believe Representative Johnson, you had asked us for this question, asked this question during the appropriations hearing. So people can, in fact, apply for MSP through a paper application, online or in person, at any one of our resource centers, and we do some automatic screening for people for MSP eligibility if they're already receiving other kinds of DSS benefits. The Advantage plans, which I recall that you did ask about, which is also Part C, those are administered by private companies. We really don't have any interaction or application process associated with those at all, but we do support people in applying for MSP.
So just to follow up on that, it is confusing, and I'd be glad to write it out, but there are people who are on Medicare Savings who also are sold a Medicare Advantage plan, so they have both. And the problem is that gets referred to the Center for Medicare Advocacy is that when they're on both, they sometimes have limited access to a network that they would have had if they were just on the Medicare Savings Program. But when they have both, they actually get limited instead of expanded services. And that was the question. And that's what I'm asking to track, because I don't think that should be. And I have some examples that I think I referred to David Seifel last year, a couple of cases. So it's been a real problem. And over and over again, people are paying out of their pockets when they're already qualified for the Medicare Savings Program, but they're also being sold by insurance brokers these policies that limit their access to what they should have if they were just straight Medicare savings.
Thank you for the clarification. So allow us to take that back and see if we can answer your question more thoroughly.
Thank you. Thank you. Appreciate it.
Great, thank you. All right, you can keep moving ahead.
I believe it was Representative Dathan, or it might have been Representative Dillon, that asked us for an update on the status of MyCT. There was a description of a portal that people could go into and just get a sense of what their eligibility might be through a screening tool and check their benefit status. And I will apologize if I misunderstood the question, but we were hoping that the response to question 9 was in response to that question. So there is a MyCT portal that was launched in fall of last year. It is fully up and running. We do have many people that are using it, and they are essentially using it as a primary eligibility screener and to really just get a sense of what they may be eligible for and to understand what other programs DSS offers.
Great. Lucy, go ahead.
Thank you. So some of my question was, if this was indeed my question, was around the it was an interagency online portal to share client data was more of my question.
All right.
And we had talked, I know you had mentioned in your testimony when I asked this question, you had said that you have kind of high level talks with, DPH and other agencies. Yeah. But this was more of a granular, detailed question. I know as part of 5001 last year, we were hoping that we would get a plan by July 24. And so I know this isn't just you. This is, a lot of different agencies. But it would be great to hear how, in your view, how we're able to facilitate that, if that plan's being discussed, was more of my question. So
Oh, I'm sorry.
if
All
you
right.
can just, kind of answer that as part of a discussion on that with the administrator.
I will. Thank you.
Thank you. Thank you, Madam Chair.
Great, thank you. All right, feel free to continue on.
There were other questions that were posed, which I think I responded to in the beginning of my remarks here today about the nursing home costs as a result of the policies issued by DPH and provide some clarification there. Happy to answer any of the questions that I can answer on that. So we can, if there aren't any, then we can move to question 2. We were asked to provide some backup to the request to increase the authorized count by 84, and then also to answer the question of how long does it take to hire. Pretty extensive paragraph here, but the long and short of it is that we have 826 positions, including all of the IT positions in fiscal year 2025. It does include an increase of 84, right, which brings us back to really almost, I would say, our not close to our pre-pandemic numbers, but pretty close of 1910. We do need all of the people that we would get with the 84 and could probably use a bit more because we do continue to see significant increases in the number of people who are applying for Medicaid, SNAP. We are also seeing a pretty significant increase as our population is aging and the number of folks that need support through our social work services. And we're also seeing quite an uptick in our child support services as well. So our position count, as you can see, was as low as 1,500 in 2023, right, and went up to 1,810 in February 2024. But given what we are seeing, and you may have seen, one of the headlines recently about our call volumes, and our call volumes are directly related to the numbers of applications that we're getting and the tasks that are associated with those applications. The numbers of positions that we have here are sorely needed, and we could probably use more, but we understand the budgetary constraints, and we are very happy with the 84 positions that we will get and plan to have a comprehensive plan in the ways in which we can fill those positions strategically to meet the needs of the people that we serve. Now, to the second question, how long does it take to hire? It really does depend on the particular position, how many applicants there are, how long we leave the posting up. In some instances, if we know that we're looking for a specific skill set and that there are fewer people in that particular category, we may decide to leave the posting up for a week or two. If we're looking for a number of people, as we often are in eligibility operations, we tend to leave those applications open longer so that we can have a larger group of people from whom we can choose. So it really does depend. I would say if you were talking to Commissioner Gilman, she would probably say that every day is a day for all of us to work together as agencies to improve the hiring process, and she's constantly working on that. We are very fortunate here, as we are in a lot of agencies, that the cooperation that we get from DAS is significant in being able to hire. So it can take from 3 months sometimes it's a little shorter, sometimes it's a bit longer. Sometimes it can take considerably longer than that, but it's really depending on the circumstances. So it's not really a question we can answer with a lot of specificity.
Great, thank you. Any questions from folks?
I guess I have one little question, and that has to do with how the intakes are being addressed. My understanding is the way that the intakes are being done is if they go in through the computer or they do a walk-in into a local office, the process might get transferred, say, to another office that isn't local to the person that's the applicant. So some of the problem has to do, and I don't know I haven't heard this lately, but I did hear this a lot last year, that the scanning process was a problem. I didn't know if you would had the chance to address or had seen an improvement in the scanning of the documents that people have provided and, for their application process. I just wondered what that was, how that was going.
Certainly. I will start to answer, and if I'm correct, I do see Deputy Commissioner Canada, who runs our eligibility operations, and I will also turn to her to answer your question more thoroughly. So thank you for that. It is true that when you walk into a specific office, we do, because of the geographic locations, we do often see people who live close to that geographic location. But processing is done throughout the 12 resource centers that we have. There was a time that predates me, and it may even predate Dr. Gifford, where we had workers that had caseloads and they were specific to the geographic area. And certainly there are advantages to that. You get to know the person, right? The relationships are built and there's an advantage to that. The challenge that we're having is that it's really no longer practical or feasible given the numbers of people that we are supporting. So we really do need to find a way to smooth out the work throughout the 12 resource centers that we have. The other issue is that the same people that are answering the phone are the same people who are determining the eligibility. We do have a breakdown of tiers that we use where people can call in, they can get basic questions answered right now. Did you get my application? I need to make a change in address. And so those questions can be answered pretty quickly. The ones that are more specific and more complicated, those then go to eligibility workers in our benefit centers, and those can take longer. The scanning is not something that I think that I know of, that we've had a specific issue with recently. But again, I'll turn this over to Deputy Commissioner Isha Canada, who does run all of our resource centers, to answer that more specifically. But that is not a concern that I've heard of late. DC
Yes.
Canada?
Yes, thank you so much, Commissioner, and thank you for the question, Representative Johnson. I too am not really familiar with any particular issues around scanning of our applications with the vendor that we have. I'm happy to take any concrete examples that you might want to share with us that we're able to go back and research for you to get a better answer. But to date, since I've been in my chair, I have not experienced any major issues with our scanning process.
Well, that's great. I haven't heard it lately, but I had heard it a lot. And since we're discussing eligibility and the process of the initial claims, I'd ask it because I had heard a lot of those things, primarily more so during the COVID problem than now. And so I'm glad to hear that you haven't heard any either. Then one other thing that I have is this is an issue that kind of goes beyond the Department of Social Services, but it is an intake issue, and that is when there are people who hold accounts that are not regulated by the State Department of Banking, but regulated by FDIC, the city banks, for example, and they have these accounts. I have a constituent that took an incredibly long time to finally get the information from Citibank through the application process, almost a year. And it really put her in a spot with her rest home and being able to pay for that. So I know that this is an issue that is it's an issue that I see in the probate courts. It's an issue I see all around. And I wondered if there is something that you have that can help us maybe look at some of the problems you've had with that. We can bring it to the Banking Commission. Maybe we can work on making sure that we can get the information from the federally regulated financial institutions so that they can help you process the claims more expediently.
Commissioner, you're on mute. Sorry.
Thank you. I don't know why that keeps happening in Zoom. I'm not even touching the computer, so that's a little frightening. But thank you for your question, Rep. Johnson. It does continue to be a very significant concern, especially for those who are applying for long-term supports and services. We try to do everything that we can, and I know this in talking to our social workers and our other workers and what we call LTSS, to try to get access to those banking records. And it can be very frustrating for the member themselves or their families to get access to that. Now, if I recall correctly, I do believe that last year there had been some legislation proposed that would shorten that time period to 20 days. And I do believe that that legislation, if I remember correctly as well, I think has been reintroduced in this session. I believe that we have actually provided some testimony in favor of that for this very reason. We do think that banks can be more responsive. We do really try our best to build good relationships with them so that they can be. But, very often they set different priorities than providing records that we would need to determine eligibility. And that does have an adverse impact on the people we're trying to serve. And that is pretty much what we're doing at this moment, is trying to intervene as we can on a case-by-case basis, and then trying to support any legislation that has been proposed by any committee to help shorten that time period.
Well, thank you so much for your work on that. And whatever you might have with testimony, I'd love to see it if you could provide it to me and to the rest of the people in our group. I think it's important for us to take a look at, and I might take some of that information and use it myself to provide testimony to the banking committee, because this is something that we're going to try. We got to figure a way to connect with them, despite the fact that they're the glorious FDIC people. they need to cooperate with us. And it is creating a problem for, I think, probably everyone nationally. So it's probably something that National Council of State Legislators should take a peek at and just kind of look at. So thanks so much for that.
You're welcome. So
Great.
Representative Gilchrist, I can't see everyone. If there's another hand up, I'm not able to see it, or would you like us to move on to the next question?
Yep, if you could just move on, no other questions at this point.
Absolutely. All right. We were also asked for information regarding the Katie Beckett waiver. I believe this is a question posed by Representative Dathan, if I remember correctly. So here we do have the total number of active cases that are receiving services, or they have been assigned a case manager. All of the data is here. We also wanted to provide you, because I don't know if this is specific to your question, but the number of people who came off the wait list in 2023 and the numbers that were added in 2023. And you can see we were able to move 59 people off the wait list, but then another 72 were added onto it. This continues to be a challenge. So those that are on the wait list, we thought it also might be helpful to provide some of the reasons why people are on the wait list. They may be waiting for home and community-based services under Husky. They may be waiting for hospital inpatient services, durable medical equipment. So there are a number of reasons why people are on this waiver. And then moving to 4, I think we could just talk about them together. We do also, because I also believe this was your question as well, Representative Dathan, regarding the number of people who are also active on the autism waiver. You can see that our autism waiver list continues to be much, much higher than I think we would like and feel comfortable with. We were able to move 186 people off the list last year, but then we had another 226 that were added. We do have an extensive list here of the services that are provided on the waiver. We would really like to see more movement on this waiver. It has been challenging for us for a number of reasons, but I'm actually I see that your hand is up. I was going to say, I was actually also then going to turn back to our Medicaid director, to Guy Wilson, to provide any more input or feedback. And I think our deputy director is on as well.
Commissioner, you nailed it. I just was going to add, for folks who aren't familiar, I know you are, Rep. Dathan, just the Katie Beckett waiver, for those of you who aren't aware. This is a program that allows us to provide Medicaid services to individuals up to age 21 who have a physical disability, who normally not qualify financially for Medicaid due to family income. So it's basically a pathway for families that are a little bit too high income to get coverage when their child has a disability. But Commissioner, you everything you said was perfect.
And quickly, and I mean, I think this is self-explanatory, but just want to be clear for myself. The wait list is because we just don't have enough money.
That's right, Representative. So most parts of the Medicaid program are in the state plan, where we need to offer it to anyone who comes, dermatology, primary care visits, etc. Some portions of the Medicaid program are in these waivers, where we're allowed to waive one of the requirements, and one of those requirements is offering it basically to any Medicaid eligible member. So for these waivers, we have a certain number of slots that are funded, And to take the Katie Beckett waiver just as an example, we have the number of slots that's in the budget, and people move from the wait list onto the program only when, well, they meet the criteria, but then also when basically a spot opens. So it's a matter of money.
Okay, great.
And
Sorry.
I think states did that in part to limit the potential financial upside of offering, for example, Medicaid benefits to somewhat higher income folks. Just was concerned about, I think, the big price tag there.
Okay, thank you. Lucy?
Yeah, I was just going to say, I mean, these are pretty expensive waiver services to move. Is that correct?
I'm sorry, Representative, I had a hard time hearing your question.
Sorry, with the Katie Beckett waiver number 3, these are pretty expensive cases, from my understanding, to really shift the ability. I'm wondering, with regards to these services, there is definitely a cliff that folks are experiencing. How do other states manage kind of smoothing that cliff out? And, you know, I'm trying to think of maybe a little bit more creative ways for us to move some of the people off the wait list.
Yeah. Okay. Any thoughts?
Great question, Representative. And if you have thoughts, would love to get them. I think the first point you made on the cost, and we'll follow up in writing. I believe the average cost for people in the Katie Beckett waiver is approximately $50,000, but we'll follow up in writing with that information. In terms of creative ways to get people off of the wait list, again, if you have ideas, would love to hear them. I think there's wait lists are really tricky, and it is heartbreaking for families who are waiting for the services. I definitely get that. I also get the fiscal reality. So I guess one thing that our team has been doing, this is not directly responsive to your question, Representative, it's a little bit adjacent. In cases where for some of our waivers, there's such a long period of time between when someone signs up and when they finally become eligible, it can sometimes be really challenging to actually find the person, particularly if the families, if families have moved or have unstable housing, things like that. So we've been reforming and trying to use better data to help find people, particularly when it's been years in the making. I'm happy to give you a briefing on that work offline. But if you have ideas, we'd love to hear them. Thanks.
Yeah, I am interested in this because, you know, it looks like it's only sort of a waiting period of like 6 years based on the sort of average of how you're moving. But my understanding from talking to the advocates that it's much longer than 6 years. And so would love to figure out how we can do that, and we can carry those conversations on somewhere else. My next question really is around the autism waiver. I know you kind of listed out the services. That was really helpful. Do you have a breakout of the 2041 on what kind of services they're waiting for, so that we have an idea what are the sort of really important things for us to tackle as a committee?
Commissioner, do you want me to take that one? Okay,
Yes,
great.
please. Yeah.
Great. Good question, Representative. And the answer is we don't, for a very good reason, which is when someone is on the wait list, we have an initial screening, we make sure they're kind of generally eligible, but then we don't start talking to them about all the services exactly that they would need. In part, we're not in a position yet to offer them until they're further along on the wait list, and it sort of would be a little bit of waste of resourcing, but also kind of not building up false expectations. If we ask people about all their needs, then we're like, okay, well, we'll get back to you in 6 years, at which point the needs may have changed. So we obviously have a general sense from people who are coming right off of the wait list. That would probably be the best proxy. But for people who are on the wait list, we don't survey, and I think for good reasons, their exact needs.
Okay, I guess DDS does their wait list by emergent emergency needs rather than sort of not quite as urgent. Do you all look at your wait list in the same sort of lens?
We don't. For people, we have the well, there for every wait list, there are criteria, and then when you make it, then people wait.
Okay, that's helpful. I'm happy to have any more discussions on this going forward. I don't want to take the committee's time, so thank you so much, Madam Chair. Thank you, Commissioner and
Thank
Guy.
you.
Great, thank you. All right, Commissioner, feel free to move.
Yes. So the next question had to do with the delivery of the maternity bundle. So we are on track to launch the bundle in September. We had already started our formal submission process to amend our state plan, our SPA, as we like to call them, our state plan amendment. And we are just waiting for CMS. There's been lots of really very good conversation with CMS where we really are anticipating that we will get a positive outcome from those discussions. We do get a lot of questions about when the maternity bundle is coming because there is a lot of interest in the doula support that the maternity bundle will offer. But as you can see, we thought it might be helpful to add a link to some of the recordings of some of the meetings that we've had in the materials there in case anyone had a deeper interest. But we are very excited to continue to work with CMS and get this bundle launched by fall of this year. And thanks very much to Guy and his entire team for continuing to raise this up as a priority. So then,
keep going.
I'm sorry, were there questions?
I don't believe so.
Okay, all right. All right. This question with respect to Husky A and the caregivers that are over 65, because we know of the limitations if they were to move to covered CT. I'm actually going to turn this over to Deputy Commissioner Hadler, who has much more subject matter expertise and can really go into the details around this. So DC Hadler, if you're there.
I am, thank you.
Yes,
I'm happy to
you're welcome.
chime in and give a quick update here. As is sort of written out in more detail in the answer here, the basic takeaway is that there are certain individuals over the age of 65. We estimate it to be a very small number, about 100 people is likely the population that would be subject to this income ban, might even be lower than that, who would potentially be ineligible for would be ineligible for Covered Connecticut due to the age limit restrictions. It's pretty uncommon for people to be 65 and older on Husky A. They usually are transitioning to Medicare and to MSP, but it is possible. And so that is something that we did want to highlight, that is one distinction between the current Husky A eligibility coverage and that of Covered Connecticut. We do think that Medicare plus they should be eligible for a Medicare savings program at this income band. The combination of Medicare and MSP is a pretty strong health package altogether. But if someone did also need additional coverage based on, for a need to wrap even around Medicare and MSP, they'd have the opportunity to be able to apply for coverage through Husky C. So that is I just wanted to highlight that is one distinction, but it's very small. The number of people who would be impacted is anticipated to be very, very small compared to the overall population who would potentially transition to Covered Connecticut under the proposal. And happy to answer any questions about that anyone might have.
No, great. This is very helpful. Thank you for this information. I think we can.
So the final question is related to Medicaid coverage of peer supports. So Medicaid or DSS with state dollars, we don't really cover or reimburse for peer supports as a specific service, but as we mentioned in a recent MAPOC meeting, we do cover it in specific circumstances. We did think that perhaps having this chart below in the next page that offers a brief description of what they are and what we do cover might have been helpful. So we do cover it for behavioral health under our accountability service organization, our ASO, and you can see that we cover it for autism, family, adult, first episode of psychosis under our 1115 SUD waiver and some of our residential programs. There is also some support under DEMAS that we thought might be helpful to mention here, and that they have some grant funding for peer support services, but that isn't necessarily Medicaid coverage. We also thought it might be helpful for you to see the states that do cover it and the states that don't. We could definitely see we are in the minority in that regard. As you see the states that have the covered service and don't. In order for us to do this, I would imagine that we would have to make some changes to our state plan and also make sure that we have enough fiscal bandwidth in order to be able to make this change. I don't know if there are any questions about that.
Any questions? I don't see any.
So Representative Gilchrist, that was the entirety of the questions that we believe were posed to us during our appropriations hearing. I hope that everything that we've provided has been responsive to the questions that were posed, and if they were not, we're happy to bring back any questions that you might have and provide additional information. But we really want to thank you for the time this afternoon to allow us to provide additional responses to the inquiries that you posed.
Well, I want to thank you. These are fantastic responses, and thank you for the conversation. If anyone does come up with or think of questions after the fact, remember we just send those over to Susan Keene so that she can make sure they get to the appropriate folks at the agency and to all committee members. Any questions or comments for the department? Otherwise, we can end early.
Yeah, so Representative Gilchrist, if you'd allow me to just thank my colleagues and peers publicly for the exceptional work that they do. It takes all of the people you see here and more to be able to do what we do and to respond to the questions and to, really perform at the level of excellence that we hold ourselves to. So I really just wanted to say thank you to them publicly for everything that they do.
Great. Thank you all.
Okay, thank you.
Sure, we'll see you soon.
All right, thank you. Bye.
Thank you.